Okay, so I can talk like this and you can still hear me. Yeah, it's okay. I'll raise my voice. It's really good to see everybody here today. Everybody doing okay? Yes. Okay. Yeah, applause for doing okay. Yes, take every win we can get. So welcome everybody to today's symposium that I am very much looking forward to myself. It is, National Family Caregivers Month. I'm curious, how many caregivers do we have in the room? We have a few. Just have us do a little interactive stuff because it's really important to be interactive. How many Vermonters over 65 do you think have Alzheimer's? Just throw out the numbers. What? 16,000. 12,000. Somebody knows the numbers, I know. This group. Okay, it's 12,800. And that's nearly 10% of adults over 65. So the prevalence is important for us to elevate because a third of our population is now 60 or older, or just about, and that is projected to continue to grow. So when we talk about older Vermonters, we're talking about Vermonters. And I think that that's really important. The other question I have for you is, just curious, how many people in this room are aging? Thank you. It's amazing because every room I ask that question, everybody is aging. By the time I finish my 5-minute welcome speech, you'll be older. So that is actually an important message for folks because, ageism is still very much alive and unfortunately well in Vermont as it is in most of the country. And people tend to think of older folks as others. Younger folks think of older folks as young, as others, and kind of try to put outside of their minds that they are actually aging every day. And so when we talk about policies and programs for older Vermonters, we're talking about policies and programs for all Vermonters. And I think it's important for people to think about what they imagine their older years will look like. So most people would like their older years to be joyous, to be filled with connection, to be filled with family, and to feel part of a community, and to have autonomy, and to have choice, and to have agency, and to be healthy, and to feel like they're part of something and have a purpose. That sounds pretty much like a human endeavor, right? And everybody wants that. But not everybody lands there. And there's many reasons for that. There's economic reasons, there's geographic reasons, there's physical health reasons, there's different factors that impact that. But when you layer dementia on top of that, you are switching or shifting the chances of achieving that. So what do we need to do as providers and policymakers and members of the community to make that dream nonetheless a reality? So that's where the notion of age-friendly comes in. That's where community connectedness for older Vermonters and older Americans in general comes in. What can we do so that folks, regardless of what their challenges are, regardless of the fact that they may have Alzheimer's, is the best years and they live the best life that they can live. And sometimes that's about impacting the environment around them. Are they isolated, alone, unable to get from their home? And if they do walk out of their residence, are they able to walk to a place where they feel safe, where the people who they interact with know how to work with folks who are experiencing those challenges, where signage is created in a way that makes it easy to find your way? Is it a park where I can sit down and stand back up again? Is a bench designed so that I can stand back up again? Is it designed in a way that encourages intergenerational contact and connection? Or is it designed to be sitting by yourself? All of this makes a difference between what the life of folks are. So when we say people are living with dementia, the operative word there is living. And that's where all of what we hear today and all of the work that we do, Age Strong, if I'm going to ask you, everybody in here, have you looked at Age Strong? Do you know Age Strong? Perhaps you're working on Age Strong. Raise your hand if you are familiar with Age Strong. Okay, and so for those of you who are not, make an effort today at the end of this, or when you go home, or, I don't know what you're doing this weekend, but spend a little bit of time with Age Strong. Just click in there. That is a joint between the entire state of Vermont. That was an effort before I got here, because I'm here a year and a half as Commissioner of Dale. So I like to say it's amazing and awesome, and one of the reasons I was drawn to Vermont. And I can say it's awesome and incredible because I didn't contribute to it, so, I can just say that. But many in this room may have contributed. It was really, it's a multi-sector, multi-year plan, and we are in year 2. So we have lots of work to do, but it is a roadmap, and it can help us get to that vision we're talking about, including the way in which older Vermonters live with Alzheimer's. Now, it is National Family Caregiver Month, and Alzheimer's and dementia, and my mother had dementia and she has passed. So I do know personally what that feels like, and that loss is so much a part of that experience for the person who has that challenge and for the families. And it's, concentric circles that go out into the community. And it's addressing that loss and filling that loss with opportunities to have new experiences that are so important. But I'm going to ask you another question. It's not Jeopardy, so you don't have to answer it in the form of a question. But how many caregivers do you think we have here in Vermont? The unpaid family care.
35,000.
35,000. Okay. Ooh, you're not guessing. Okay. So it's actually 20,000. 29 million unpaid, total hours of unpaid care. And the total value of unpaid care is $773 million. So there is a big cost for families, for many, that is a loss of income that comes in. And the efforts, and some of them that have begun to take hold over in recent times to provide some type of support funding through Medicaid and other approaches. But anything and everything that we do as a community to support caregivers is supporting an individual, a family, community, and actually the state as a whole. So I want to just take a moment and say thank you to all the caregivers in the room. This year's theme is about plugging in and being able to get quick access to resources. There are a number of efforts that are available in Vermont to help with connecting to resources. I see many of the folks from the AAAs here. Raise your hand if you're from one of the AAAs. Yes, go team. That support caregivers. And I know that this we have been able to get through a collaborative with UVM and Dale and VDH, designated dementia care specialists and dementia care assistants. And those are like navigators and helpers for a system that can sometimes be, daunting. I also want to take a moment because the relationship between Dale and VDH around older Vermonters is really something to celebrate. The work together is extraordinary, and I wanted to take a moment to introduce the new commissioner of the Department of Health. Have you met Dr. Rick Hildebrand? Well, meet Dr. Rick Hildebrand. And we're not going to embarrass him, but he's awesome. So he is an internal medicine doc, and before he came here, he was Chief Medical Information Officer and Medical Director of Hospital Medicine at Rutland Regional Medical Center. And so there is a lot to learn and to know about Dr. Hildebrand. He is now part of our AHS executive leadership team, and so it's just wonderful to have you here and in the room with us today, and just really here as part of AHS. So thank you. And now I am going to hand this off to another amazing individual. Isn't it great we have all of these fabulous people? Howard Goodrow, who is the Executive Director of the Vermont chapter of the Alzheimer's Association. Where are you? Up there? He's going to take it from here, and I want to just thank you once again for being here and for all of the work you do and the way in which we collaborate, because our community, this community, makes a difference too. Thank you.
Thank you, Jill. And I'm very excited because I had no plans for this weekend, but now I know Age Strong is sitting there waiting for me to dive into.
Hallelujah.
So that's very exciting for me. Thank you all. Thank the organizers for putting this day together. It's the second year. It's very exciting to be here. I think you've chosen a good way to spend your Friday. A great deal's happened since the last time I stood up here last year. Putting aside many of the external forces that are making our collective job more challenging at times, we've been able to land a few blows against the Alzheimer's Association this year. Last year, we discussed the two new drugs that have shown to slow the progression of the disease by up to 35% in certain patients. At the time, the only way to get those drugs was to travel to an infusion site, possibly 2 or more hours away. By the way, that sound, an angel gets its wings. In August, the FDA approved the first subcutaneous dosing of one of those drugs, Leqembi, that can be done from home. This could be potentially game-changing in rural states like Vermont. The Alzheimer's Association's U.S. Pointer study released its finding in July. This was a 2-year clinical trial to evaluate whether lifestyle interventions that simultaneously target many risk factors protect cognitive function in older adults who are at increased risk for cognitive decline. Spoiler alert, it works. The study found that a structured lifestyle program focused on things like healthy nutrition, physical activity, cognitive engagement, and health monitoring improved thinking and memory over 2 years, keeping brain function from declining as it normally would with aging. In recent months, a class of drugs called GLP-1, specifically semaglutide, I'm sure most of you are familiar with these, widely known for treating type 2 diabetes and obesity, has gained attention for a surprising new possibility, helping to treat Alzheimer's disease. It's like the miracle drug. It's unbelievable. These findings could represent a pivotal moment for Alzheimer's care, shaping how the disease is treated and managed for years to come. A readout on these studies will be coming later this year. 2 blood tests were approved by the FDA in 2025 that will not only allow us to better diagnose the disease, but equally important, allow us to rule it out with nearly 98% accuracy. If you have any interest in seeing those tests covered by insurance, please talk to Meg Polite, our policy director, who's here, most of you know, to see how you can help her get that done at the State House. These are just a few things happening on the national and global scale that have been supported through the Alzheimer's Association. You've likely noticed that announcements around treatment and testing have been coming on a very regular basis over the past few years. That's a huge shift from just 5 years ago, when hope was all we had to hold on to. Now we have results, and those results are building off each other. I'm sure you've all played Jenga before. Everybody's played Jenga. Up until recently, we were all studying the stack, trying to figure out which one do we pull out. But the game hadn't started yet. Well, as they say, game on. Picture each of these breakthroughs as blocks being removed. It's much easier today to imagine a time when that one crucial block is removed and the disease comes tumbling down. Here in Vermont, the association continues to reach more of your neighbors and friends, corporate partners, and civic groups with education and awareness programs. We have over 20 support groups set up across the state, helping people through a very difficult time. We have a very small staff and can't do everything alone. In fact, our model is to empower volunteers to help educate and support those impacted. We also utilize volunteers at the State House to share their stories and help move legislation that, if not for personal stories, would not ever see the governor's desk. So I encourage you all to be involved in any way you can be. Finally, we have many volunteers who support us in our fundraising efforts. The Vermont chapter is one of 74 chapters across the country for the association. Our 2 signature events as an association are our Walk to End Alzheimer's and our Do What You Love to End Alzheimer's DIY event. Vermont's the #1 per capita fundraiser chapter in the country for both of these events. We also have a backcountry ski event coming up at the end of January that kind of goes around Camel's Hump. Fingers crossed for some snow. I don't often say that, but I'm saying it here. And our Reason to Hope Gala, which takes place on April 30th. Fingers crossed for no snow. We'd love to see you there. If you want to be involved in any way or know anyone that may need our support, please let one of us know. I can't close without telling you that I do this work in large part because I lost my mother 2.5 years ago with dementia. We all have a story. And whatever your reason for being here and for doing the work you do, I just want to say thank you. Nobody in this room can solve the issues we face alone. But together as a community, we have a fighting chance. If you can, this is my personal plea to everyone, if you can, reach out to a caregiver and offer them a bit of respite. And if you're a caregiver, please accept it. With that, I'd like to turn the program over to our keynote speaker for today, Dr. Danny Cabral. Dr. Cabral is a dual board certified neurologist and psychiatrist specializing in Alzheimer's and related diseases with over 15 years of experience in Alzheimer's care and clinical research. She's an assistant professor in neurology and psychiatry for the University of Arizona, my wife's alma mater, and has served as principal investigator for multiple Alzheimer's clinical trials. Dr. Cabral is the founder and medical director of Brain Love, a direct specialty care practice supporting patients and care partners facing neurocognitive diseases of aging. Please help me in welcoming Dr. Cabral.
Thank you, everyone. Good morning. You guys are really fun already at this early hour. Wow. Thank you to Vermont, and while you're the highest fundraisers for these events, amazing. And thank you to the Alzheimer's Association for all that you do. So today, I'm going to talk about what my passion and soul path is that I'm able to do now, which is combining high touch with high tech, and that's really what we need for excellent Alzheimer's care. There are my disclosures. I'll be using these abbreviations, which I'm sure you all know. A little about me. So I've been in this field in general for 20 years. started working for a hospice dementia program when I was pre-med in a big hospice in Arizona, and they were pioneering dementia care in hospice and palliative medicine. And what I saw was ultra high touch having a huge impact on people who previously were viewed as an empty shell. There's nothing left there. But in this setting, we were doing, which is more popular now, pet therapy, music therapy, massage therapy. These things weren't used readily at that time. And to see the way individuals who may have not moved or spoken for weeks lying in bed would start tapping their toe. They would open their eyes, smile. Like, these are huge changes, right? And so for all of us, maybe tapping our toe isn't a big deal, but that is massive. And also to see, you know, that person would calm down, you could see it physically and energetically. And their family, what happened to their family, it was so therapeutic. And even if that happened one time, that changes their experience and their grief after, and they can feel like they did everything they could for their person. So that has informed everything I do in this field. And I went to Brown for my residency in neurology and psychiatry under working with Steve Salloway, who I know was here last year for the inaugural talk. And I always felt like the neurologists were missing something when it came to working with this population, and the psychiatrists were missing something. And so I thought I should just do it all and try to put it all together. So here we are. I've been working in a large hospital, memory center in Phoenix, state-of-the-art everything, all the bells and whistles, doing clinical care, clinical trials, led the studies of donanemab, lecanemab, gantenerumab, semaglutide, aducanumab, all of these, which I love clinical research, but still I was hearing patients and families say, like, they're not getting their needs met, right? And I was so busy, even though I'm a psychiatrist, I'd see a family member like breaking down, and I knew, like, I have so many other people to see, and so luckily we had a social worker, but I couldn't give them what they really needed. And so I started a practice this year called Brain Love, where it's solely focused on working with this population. We see patients and care partners separately, and I'll talk a little more about that. And that, I hope, will basically help everyone see this disease with new eyes, what's actually happening and what's possible, and that you all and your vision and ideas matter so much. And having, like, floated through all these different groups and, like, hearing, like, how they talk about things, and there's so many disconnects, what I'm really hoping to do is help start, like, a new language that everyone can get excited about and understands why we need both the high touch and the high tech. So we heard from Howard. Thank you you covered two of my slides later on, which all of the exciting advances we've had in Alzheimer's disease. And we're on the verge of having an approved Alzheimer's secondary prevention treatment that's getting read out early next year for the AHEAD 3-45 trial for using lecanemab for people who have no symptoms but are building up the Alzheimer's changes in the brain. That's crazy, right? Can you believe that's already happening? Yet, these new approved treatments that you heard about and diagnostics are not getting the uptake that everyone expected. And so we're going to talk about maybe some of the reasons why that is. Major care gaps remain, and families still leave appointments with fear and confusion, as you all know, very well know. So today we'll talk about, what I just said, about how, these things aren't getting taken up, and so how can we get people into these amazing treatments and diagnostics, and a framework for integrating high tech with high touch. I'm going to talk about AI in Alzheimer's and what's already happening, and also for people that tend to not get excited about AI, how actually you should get really excited, because it's going to help you all carry out the important things you're doing. And then a consideration of why this approach is a good fit for rural communities. So Alzheimer's care is perfectly ill-suited for the U.S. healthcare system, which is increasingly reactive, transactional, dehumanizing, and cookie-cutter, and obsessed with high volume over quality. So, as an Alzheimer's specialist, and I also see Parkinson's, it takes 3 minutes to 5 just to get the patient and the family to the room. Oh, but they have to go to the bathroom when they get in the room, right? So, and then they get in the room, and then I'm asking questions of 2 different people So there's no way anyone could ever do a visit in 15 minutes, right, and effectively. And so it just doesn't work in our system, but that we can change that. And then most of what is needed for excellent Alzheimer's care is what I call non-medical or psychosocial, spiritual, relational, and so on and so forth. And there's this increasing disconnect between what these different groups are saying, what Alzheimer's researchers are saying, the medical community, the public, patients and families. So I'm hearing all these things, and you probably know, if any of you go to the Alzheimer's conferences like the AAIC, like everyone's so excited, and you know, the companies that are making the assays and things are like salivating, like we're gonna get everyone diagnosed and it's gonna be great and it's gonna fix everything, and like it's, and I just, now that I'm like out in the real world more, it's like, no, that's not going to work, and it's not working. And I think primary care providers know well what it really takes to care for people, and maybe that's why they're not running to get everyone diagnosed. So I'll talk more about that. And then oversimplification of messaging. Calling an Alzheimer's diagnostic tool simple is completely inaccurate. So yeah, we can, so there's so much room for improvement, and you guys are gonna take the lead on that. So let's break down this. The way I think about it is excellent Alzheimer's care is, with the current technology and treatments, 15% medical and 85% non-medical. But you need both. So the medical are the things we know, the evaluation, the diagnosis, the treatment. Now we have anti-amyloid therapies, risk factor modification. And then there's that 85%, that psychosocial, spiritual, relational, community connection, care partner support, thinking about care from a dyad perspective. Now, what I see is that people, these two tend to be at odds with each other, and people who have one or the other tend to struggle more than those who can access both of these areas. And so I think of this as the medical is more the high tech, and the non-medical is the high touch. Non-medical, there's a lot. And this is a journey, right? A diagnosis doesn't just happen in one visit. It usually takes at least a year from my perspective for everyone to kind of settle into it. But then it evolves and it's unpredictable. But for those of us who are passionate about this field and you've been in it a long time, we know how to get from people what they need and support them in those, as time's going by within this large group of tasks. Now, as treatments and diagnosis advances, maybe the non-medical percentage will decrease, like in, say, cancer, where people are getting treated, cured before there's any symptoms, right? So they may not have so much grief and mindset work and ripple effects in the family that need to be addressed. So I don't know if these percentages are true, but there will always still need to be the non-medical. But when we can diagnose at age 50, clear out the amyloid and the tau and many other things that are going on, and get people on a multimodal lifestyle intervention, well, that would be amazing, right? I already kind of alluded to, so why don't we get this 85% built into the healthcare system? There's a training gap. Neurologists are not well versed in this psychosocial care. And it seems like neurology attracts people that maybe don't even really like this kind of stuff sometimes. So we like to sit in the room and like talk about, like break down, like, well, what kind of aphasia is it? And like, could this be PSP? And everyone gets all excited. But then when you go talk to the patient and family, they're like, okay, like social worker, please like talk to them about like what's actually happening. And then you hope that they hear what the social worker is saying, because then they're gonna not know what's going on and not have clarity. And there's a lack of clinical resources and support. So not to hate on neurologists entirely, because I am one, but they're in a tough position because by the time the patient sees them, they're usually at a breaking point, and they really don't have much to offer, as they're telling you, and that's not their fault, but they want to help. There's a payment gap, of course. There's very little reimbursement for the non-medical. There's the Medicare Guide program. That seems to be a positive advance. They're giving it 8 years to find out if it's going to work, so I'm too impatient for that, but we'll see. There's a role gap. Care partners are expected to fill 20 clinician roles unpaid, and of course the care partner often doesn't even get brought into the visits, frankly, so there's a lot of room there. And then the cultural gap in terms of the stigma of a dementia diagnosis, any of these issues, and then we hate aging in our culture and society, and that's negatively impacting all of us, even young people who I think are part of the mental health epidemic. And young people is related to the fact that they are increasingly not even in rooms with people over 50, and they're not, I think there's something that's, young people get nourished by being around older adults, even if they're not, maybe directly even interacting. And so I feel so lucky in my job, and I'm sure all of you, I often leave visits feeling like I've gotten more out of it just by being in the presence of these people who have lived these amazing lives, and they're, still so vibrant. So a little about the Guide program, as you probably know. So this is an 8-year demonstration project to see if some support for caregivers and trying to keep people in the home longer with things like dementia care navigation, senior living communities, home health agencies getting funding through Medicare for these services. So we'll see if this shows that it causes, they want it to show decreased costs ultimately, decreased hospitalizations, unnecessary medications. So we'll see if that pans out. It's tough when you're fitting, again, the fact that it's ill-fitting, this disease, for the healthcare system, and then trying to fit it into the way we work our healthcare system and how we show value. I hope this shows that it's successful, but I'm not sure what will happen. Average wait times to see a memory specialist. So it can take years to see a memory specialist, and the way I've calculated it is by the time a person is willing to go and then gets to see a specialist, it's about 8 years, in Arizona at least, because it usually takes like 3 to 5 years just for the person and the family to decide to tell the primary care, and then so on and so forth. So this is a recent RAND report that was put out, and you can see, so Vermont's on the better side here technically, but, and this could be geriatricians, neurologists, or geriatric psychiatrists. And as I mentioned, by the time a person gets in, it's usually, the family that's often bringing them in. Symptoms have progressed, care and costs have increased, greater care partner stress, overall needs are greater, crises are imminent or have already happened, and so when they come to see me, the care needs are not achievable, or the expectations, like they're like, I hear, families say, okay, I finally get an appointment with a neurologist, and then, you talk to them 6 months later, and they're like, they feel worse. It's sort of, it's demoralizing what happened. And that neurologist also is demoralized because, again, they can't provide what is needed at that point. And if we could only give that comprehensive evaluation and support earlier. The limited reimbursement for high-touch services. So it's, it's ironic that we say non-pharmacologic is the first-line approach for behavioral and psychologic diseases of dementia, but it's not reimbursed. So the expectation is that clinicians are going to take the time to counsel. And, we're all, those of you in this field, especially like Rachel Wiley, what she does, we have to be detectives to figure out like what's causing the agitation, and you have to know the patient and family to figure that out usually, and no one, very few people have the time or the know-how to do that. So, so there's OT-based programs are effective in improving caregiver skills, confidence, and quality of life. And when you have an Alzheimer's specialist OT, they're like modern day miracle workers. And so the fact that this isn't readily reimbursed is really frustrating. Strong evidence for things like music therapy, pet therapy, massage therapy, reminiscence. So we have good evidence for this, yet it's not reimbursed by Medicare or payers. And, they say, well, the data is, they use different protocols, you can't standardize the results, you can't interpret, which I think is baloney. because think of all the things that our healthcare system pays for that don't have any data. There's so many devices that surgeons implant in people that don't have strong data. I love physical therapy, but when you go and everything they're doing, there's not strong data for every single like intervention they're doing, but yet that's one of the highest reimbursed services is physical therapy, and it's like justified. Physicians and clinicians feel like, everything physical therapy, which is probably because it does get reimbursed, so they know they can offer something. But these things are very effective. So I'm saying this in terms of like policy change, coming together. Can we get music therapists together who are doing this and passionate about it and demonstrate how effective it is? And so that's part of what I'm trying to also get out there. Now, why is high touch or caregiving work paid less, even though we depend on it? This is likely rooted in gendered history, women's work, lower value, not skilled expertise. It's a calling, and it's characterized as low skill, and we're not supposed to ask for compensation for caring. We should just do it. And women tend to have done this over time, been willing to do it. You can't see, it's harder to measure the results when you're preventing crises from happening, and the savings show up in other ways. There's weak labor power and policy gaps. There's more women, immigrants, and people of color, so often non-unionized, historically excluded from labor protections. And there's a phenomenon where when men start to enter a field, the wages do go up. Like this has been seen in nursing and other fields. So this needs to change. And so we can talk more about that in a minute. Now, I'm going to shift to dementia stigma, the hidden force that can shape the whole experience. Now these diagnoses like dementia and Alzheimer's are by surveys shown to be the most feared diagnoses by most Americans. And many people, and this is hard to measure, don't pursue detection or diagnosis because they don't want that label. And from what I think, they're not aware of that being a reason they're not walking toward getting diagnosed. But what we do see is that, often after a diagnosis, people's worlds will suddenly get smaller. They withdraw from doing things, which as a physician and neurologist, I think they should still be able to travel technically. Like this person's mobile, they have mild, cognitive impairment, or, but for there's different factors that are involved. But there's a feeling of I'm a burden and there's not much out there for me. So this needs to change. So I've coined this term, which only about 5 people know about at this point, but I call this dementia dehumanization syndrome. The premature withdrawal from meaningful roles and relationships, loss of perceived self-agency and identity, internalized stigma and anticipatory grief, and psychosocial decline disproportionate to clinical symptoms. The stigma, this is coming from internal, from family as well, for themselves, in terms of where they're sitting in this, but also towards their person, and from the world, which there's very little welcoming, adaptive programs for people with these brain diseases. Even for people who have mild symptoms, it's hard to access things. So I'm part of something called the Initiative to Change the D Word, which is trying to get rid of the word dementia. And I have never really liked that word, and I didn't think it was very accurate. But I've committed to trying to not use it at all. So it was coined in the 1700s. It means, from Latin, out of one's mind. And it needs to go to the wayside, like the word imbecile and idiot. Those used to be medical diagnoses. Now I know this is the Dementia Symposium, and I'm still like, you're good to use the word. It's really hard, to not use it, because And I know we're not intentionally projecting that, but there are people that, as we get older, they say, I'm not going to willingly, voluntarily get that put on my record and then be subjected to all of that. And I think those people, I can relate to that. They're really strong and they're still living their lives. They're still getting out there. So what you might say, well, what should we call it? Well, that's a whole other conversation. I'm happy for us to brainstorm what we should call it. Now, what all of this looks like in real life is get the diagnosis. This is happening, as you know, right now. Follow up in 6 to 12 months. So then the world gets smaller, the patient and care partner, the family, they fade away from their beloved activities, communities, relationships. The family becomes the care team, takes on many roles, and then the care partner becomes chronically stressed, and often healthy behaviors and overall health declines. Meanwhile, Alzheimer's science is progressing rapidly, and all the researchers are cheering that now we have effective treatments and we can diagnose so early. It's amazing. And here we are. We already heard, thank you to Howard, all of these advances. I think this is just really nice, the way this is laid out from 1906, when Auguste Dieter, her brain was viewed under the microscope by Dr. Alzheimer and found these amyloid plaques and tau tangles. And now you can see, I added to this, more recent since this graph came out, but even brexpiprazole was approved for agitation due to Alzheimer's disease. So many exciting things. And so we're moving, if you see on the bottom, we're moving from a clinical defined diagnosis to a pathologically defined diagnosis, so biologically driven. And you've probably seen a graph like this. So the change from the x-axis, we're going from cognitively unimpaired to preclinical Alzheimer's, which is when there's no symptoms, but the changes are building up in the brain, to mild cognitive impairment, to more cognitive impairment that's functionally impacting the person. And we can see the amyloid levels are building up. Oh, I just realized I have this pointer. Oops. The amyloid plaques are the first things to build up, and you can see how quickly they build up in that preclinical period. And then the tau tangles coming on later. And so these have clearly been targets for treatment, and we have some treatments effective at removing the amyloid plaques now. This is the framework that many of you have probably heard of, the ATN framework. So this is like in cancer, we have like the tumor, lymph node, metastases, TNM system, sort of akin to that. Biologically characterizing people is, do they have elevated amyloid plaques? Do they have abnormal elevated tau? Do they have neurodegeneration? So you have to have Alzheimer amyloid positivity to be considered to have beyond the Alzheimer's trajectory. And you have to have tau with the amyloid to have definitive Alzheimer's disease. Now, something else we've learned thanks to brain donors is that it turns out most people who have one neurodegenerative disease pathology in their brain actually have more than one, and maybe 2 or 3 or 4. And wow, so that has huge implications for clinical trials, diagnosis, and treatment. And this makes my brain explode as a clinician. So this makes the researchers salivate. And as a clinician, you're thinking, okay, I'm getting this Alzheimer's blood test, but then this person has some Parkinsonism, so then maybe they have Lewy body disease too, and oh, they want to be in a clinical trial, so can I even put that they might have Lewy body disease on their record, because then the clinical trial for Alzheimer's won't take them, but I don't know for sure if they have Lewy body, because I can't, like, you know, I'm not a wizard, so there's this huge disconnect of what actually we're faced with as clinicians. Exciting advances, though, in anti-amyloid therapies. We know about Leqembi and Kisunla. Those were approved in the past 2 years. I'm a fan of those. There's a subset of patients that absolutely benefit from these, and it's finding those people and finding them early. Because it does certainly look like the earlier you start using these treatments, the better in terms of slowing the cognitive and functional decline. And that's bearing out in the real world too, as we're getting more months and years of people on these medications in the trials. I just included all of the other drugs in this class from the past that had negative trials, because we learned so much from every single participant who were in every single one of these trials that led us to have these approved treatments now that are more effective in helping people. So that's a plug for clinical research involvement. And then just seeing, this is the Jeff Cummings every year puts out this treatment pipeline that we can see all of the Alzheimer's treatment trials that are happening. And I encourage you to just Google this. Every year you can see this pie chart. And there's 182 clinical trials assessing 138 drugs right now. All right. Let's shift to AI and Alzheimer's care key innovations. Can you tell me, how do I get the pointer on here?
Can we know, but I'll pretend.
Okay.
I don't know.
Do we have to pull this out?
Maybe that's.
That could be the answer.
Yep, it's that little button right there.
Okay.
Good
Go
one.
ahead. Thank you. Okay. Team effort. Okay. I'm not going to go through all these, but it's really exciting what's happening. And I would say, especially for rural areas, it's important to know what's happening and dig into these, because these are really going to help support you getting high quality care to people, especially who are not close at all to any kind of medical center. And let's start I just highlighted the ones that I get most excited about. So for diagnosis, what we need is an accurate risk algorithm that's looking at a number of factors that is going to tell us, is this person who's cognitively unimpaired, who has like very little symptoms, going to progress to more advanced stages of functional decline due to Alzheimer's disease or something else? And so there's risk scores that you can incorporate, things like cardiovascular health, ApoE status, so that's the Alzheimer's risk gene, age, family history. When I say cardiovascular, like high blood pressure, high cholesterol, diabetes, demographics, sedentary, lifestyle factors, and then can incorporate things like amyloid, levels and tau levels from blood tests, and say, okay, yes, you are at this risk group, not like a yes or no, which is an oversimplification. It's never going to be like that, but it's like you have a 65% chance of progressing to mild cognitive impairment within the next 3 years. Do you want to start this treatment, this drug, or you can, we can wait and watch, and you can get into this lifestyle modification program? That would be so fantastic, and I bet a lot of people would be doing more exercise if they heard that. And then treatment, so forecasting disease trajectory, data-driven subtyping, so things like, could this be Alzheimer's with Lewy body disease? If you have anyone that's had quite a rapid progression from what they were diagnosed with Alzheimer's disease, they might have had a mixed Alzheimer's Lewy body disease. That seems to be a more malignant course when people have both. And this is based on looking at brain autopsy studies, and we can look back at their clinical data and see that that's what's happening. Then we can have in prognosis, you can have identification of responder subgroups. So who should really be getting Kisunla and Leqembi? In the trials, we're just seeing like the average benefit, but there's certain people who benefited a lot more than others. And so we can find out. And then ARIA risk prediction. So ARIA, amyloid-related imaging abnormality, is that risk of brain bleeds and swelling from these drugs, which sounds scary, but actually it's very manageable, and we catch it usually before there's any symptoms. But this way we could determine, well, who's really are you at high risk of that? And that's very meaningful. Say if you're 80 years old or 85 and you have a pretty full life and you're pretty healthy, and do you want to take that risk of these drugs when, if nothing else intervenes, maybe you could live till you're 100, and if you do, take them and not progress. So this could be helpful. And then care delivery, I think about how can we connect care partners more with technology that can help them in the short term if they notice their person's had some kind of change and they're worried, and you have, say, this is even like very basic, but a ChatGPT kind of platform that gets to know your person. So if you're the care partner, you're like, okay, they're suddenly like, getting aggressive and fluctuating and sleepy, and then the program will ask questions like, are they having foul-smelling urine, or did they not sleep well last night, or there been any medication changes, and then kind of try to determine if they need to reach out to their healthcare provider sooner or later, and maybe even that information gets sent to the healthcare provider, who it's channeled through a brain health navigator kind of person. And that's like the virtual agent check-ins and fall risk and mobility monitoring using sensors and predictive models. So I like all of these. A lot of times gadgets annoy me as a clinician, and people come with all this information, and I'm like, I don't know what to do with this, and it takes a lot of time, and they expect you to analyze and interpret that whatever they got from some company that they bought this thing for $300, and so it's it's good and bad. But again, some of these, I just call them gadgets, are paid for by Medicare, and why aren't some of the care services paid for by Medicare, right? So we got to start making these arguments more loudly. Given all these advances, what could precision medicine look like even next year, given that it sounds like this AHEAD 3, 4, 5 Alzheimer's prevention trial will turn out to be positive. So what that means is that probably anyone 55 or older will be a candidate for these medications to normalize the amyloid in the brain, because it's elevated, and they're on the pathway to Alzheimer's symptoms. So this is very much happening soon. So we have the blood-based biomarkers. There's risk profiling, like we talked about, like developing a risk algorithm, and then we can expect anti-amyloid treatments in conjunction with targeting lifestyle intervention, such as through the Pointer trial that we heard about, and then a greater safety infrastructure. So thinking about, continue thinking about for Vermont, like how could this look for your, late midlifers, your geriatric Gen Xers, and so forth. The opportunity in front of us. New Alzheimer's science opens the door for earlier detection with all this targeted treatment and prevention. It's really an exciting time, and as people often say, it's such a better time to get diagnosed with Alzheimer's disease than even 3 years ago or 5 years ago, if that was going to happen. But precision science without precision relationships fails. When people get a diagnosis without emotional or relational support, that leads to anxiety, demoralization, shame, avoidance, and dropout. And we see this all the time, and now that I'm in private practice, I'm seeing a lot of people coming in who got a diagnosis, it's always like 2 years ago, and I didn't really believe it, and now it's continuing to progress, or whatever the doctor said, like there was some disconnect. So it's hard to know, and I'm not, again, trying to blame the neurologist, or maybe I am, no, but it's the system. It's the system, but people dropping out, opting out. So Alzheimer's disease community calls for early detection with these simple blood tests, and as I mentioned, this is lost on PCPs who understand the complexities of medical decision making. So yes, okay, drawing blood is simple, but giving a diagnosis of Alzheimer's disease or getting a blood test result it's indeterminate, it's in this intermediate. So what does a primary care provider do with that information in a person, especially who has minimal symptoms, knowing that as we get older, I'd say over 40, there's so many reasons to have memory loss, cognitive change, and so even with this slightly positive blood test, it's really hard to know what to do with it. And then there's the often long and unpredictable Alzheimer's journey that primary care providers know exists, and they may not be is excited to jump into that because they don't have the resources that they know are needed. So I don't think it's so much about increasing the knowledge of primary care providers. It's actually giving them, all of you guys to help them do what they need to do. So the diagnosis and see you in 6 months. I think that we traumatize our patients and families, and we don't do it on purpose, but as I mentioned, there's many reasons why this is happening, and we're all just really frustrated about it. So from my perspective as a clinician, in terms of AI proofing your job, if we keep acting more and more like robots, well, we're going to be replaced by robots. So we have to keep pushing the human part forward. But how do we do that? And I feel lucky that I stepped out of that in many ways. But yes, it comes with risk to start your own practice. But to me, I thought, well, we have to have we can't have these restrictions on us to see what's possible. But we really are all faced with a challenging situation currently. So making the case for a high-touch, high-tech model in brain aging care. I think the US Pointer trial is a beautiful example of this. So well done by Dr. Laura Baker, and I put the reference at the end of the PowerPoint. So this was a 2-year nationwide clinical trial on multimodal lifestyle intervention for older adults aged 60 to 79 who did not have significant cognitive impairment, but were at risk of cognitive decline given these lifestyle risk factors, cardiovascular risk factors, demographics, diet, things like that. So they intentionally enriched this cohort with diverse, underrepresented individuals, and they had 2 intervention arms. So everyone got something out of this because it would be unethical to not really give them something. But there was one arm that was structured, higher intensity, higher touch. They had regular peer meetings, 38 meetings, goal-directed intensive coaching and support. Then the other arm, the other 50%, got self-guided, lower intensity intervention, same broad set of recommendations, but with only 6 meetings, so much less touch points. And they were looking at a global cognitive composite over the 2 years, covering various cognitive domains. So what they found was that both groups improved in this global composite score. The structured group, though, improved more in a statistically significant way. So, in thinking about the whole industry of treatments for memory and people who are concerned about their memory, if this was a drug result that was being studied, improved cognition in people who are 60 to 79 by this much, like this would be flying off the shelves, right? But this was it's exciting, yet it's still unclear how to implement this in our healthcare system and in our society. But what we saw, some highlights, was that those with lower baseline cognitive function had greater benefits, and that was regardless of ApoE status. So sometimes we see in different interventions that people who are ApoE4/4 carriers may have less of a benefit from certain things that are targeting Alzheimer's disease, but here we see it didn't matter. But that kind of those who were higher risk, worse off, higher risk of going on to develop Alzheimer's symptoms, had a better benefit from this multimodal lifestyle intervention. And so this could make a big impact across populations. The big take home here is that a high touch, high support, high structure program really helps people. And how do you make that happen? Well, Rhonda, we were just talking for 5 minutes, and she has a million great ideas for what Vermont should have going on. But we talked about how do we get this high touch, high structure system in a cost-effective way? And I think an untapped group of workers are students and young people. And thank you to Marissa, who I just met earlier, who's getting young people, wherever you are, excited about, there she is, about being in these fields. So young people may not even know that this is such a great field, just working with aging populations, because they're just not around older people, and it's just not the normal thing to do. So we have to make them aware and give them these experiences, and people who are going to health professions really want to get just any kind of exposure. They're so happy, but you have to give them structure, right? You're not gonna let like a 19-year-old just do whatever they want, like when they go meet with the patients and families, but they're also gonna be more knowledgeable about tech and AI, and so they can carry out some structured systems and be the nudgers and the following up on these personalized treatment multimodal plans that happen. And so let me know how that goes. And this is just a breakdown of what this study did for high-tech portions and high-touch. And hopefully you'll be able to get these slides, because I put tons of information in them for you to look at later. So this is not an easy study to carry out, and it was so well done. And the fact that it's positive, we're all elated, and most people shy away from most researchers leading these studies because they're really complex, and it's much easier to say, you take the active pill, you take the placebo, and we do these like set things, and then people pay us, lots of money when it gets approved. All right. So, moving to what I'm doing with Brain Love. Now the doors opened in August. It's a proof of concept direct specialty care practice. We care for patients and care partners and both. And the way I think about it is we're trying to figure out like what's the most rational, cost-effective, efficient, personalized care pathway. I love working with older adults because they're all so unique, and everyone goes off in their different direction, but it makes that really complicated, how many things you need to ask about and learn about. So how can we, what pieces of information can we get via like digital cognitive assessments, and when do we need humans, and how do we make this all work for the family with their preferences? And then you have adult children across the country. Sometimes they're the most vocal, and which actually that kind of makes sense. But you want, how can we get people's needs met? Because when, especially when I was in my, regular hospital job, when I have a family member calling me in crisis, and it seems like it's more their crisis than the person, like my patient, right? It's like, I don't have time for this, right? And I don't, right? But like, that's not okay, because that can actually lead to just for the whole family, right? Because maybe that's the person that drives the ship. So by dismissing and discounting that person's concerns in their moment of need, it can just blow up. And then you lose the whole family, even though like I've worked so hard for 2 years with this family, and so that we have to like figure out a better way for that. And there's so many people and technologies that we can incorporate. So we have an interdisciplinary team. We have myself. We have medical assistant. We have someone called a brain health advisor, and did I say neuropsychologist? Recreational therapists. We have other partners as well. It's not a one-stop shop. There's just way too much to do, and we don't have the expertise to do it all. And there's so many amazing agencies, people, companies doing great things. And what it's about is the patients and families trusting us, and us giving specific recommendations at the right moment. Okay, you need a in-home care companion. Okay, these are 3 companies that work in your area that I know, like, and trust. Call them. It's not, here's 3 pages of, companies, start calling them, and good luck. And actually, you don't even need that right now because you have mild cognitive impairment, and you guys are, you're still working, so you didn't even need that. So it's like the timing has to be right. We have 3 membership options, so the patient only, the care partner only, or the dual patient plus care partner. The care partner is where I'm basically their psychiatrist, mental health, well-being. It's a holistic, comprehensive discussion, but certainly geared towards their care partner role and grief and resilience related to that. And then we have dual patient and care partner, which that's, at this point, it's all older couples where, I don't know if it's a coincidence, but it's the wife has moderate to severe functional impairment due to Alzheimer's, and the husband is the care partner. So just some things that are different about what we're doing, and I'm doing this based on my years of experience. We do a virtual orientation with the brain health advisor about our model. Then I think this is a big difference that how we're doing things. So we have our neuropsychologist do a virtual brief cognitive assessment, and it's about 90 minutes long. She does a clinical dementia rating scale, a MoCA, and a PHQ-9, and she takes a great history. And she's really wonderful with the patients and families. So even for people who have test-taking anxiety, or they're just, they're scared about what's happening, she does a great job. And so when I get her report, it's so amazing, the information I have, whereas before, when I'd first meet people, it was like, I just asked, it was just so many questions I had to ask, and I couldn't narrow down and focus what I was doing because I needed to get so much information to try to figure things out. I think about, could I just have a digital cognitive assessment where they get an email and they do, a 15-minute or a half-hour long assessment, and then I get that report? And to me, no. The information I'm getting from this neuropsychologist is really important. And then at that point, we've staged or given a first attempt at staging. And to me, staging, is it mild cognitive impairment? Is it mild, moderate, or severe dementia? The new terminology is stage 3, 4, 5, and 6 through the Alzheimer's Association recommendations, so we're starting to use that. But if someone has moderate to severe, I take a different approach entirely in the visit and use that time much more wisely than asking them in-depth details about specifically, their language impairment, if that's not really impacting their life. So then when they see me, I do what's called the brain tune-up. And so this, Rhonda and I talked about, some places are starting to think about doing something like this when some people hit a certain age. So what we find is that there's so many reasons that people can have cognitive impairment as they age, and most of it's not Alzheimer's. So there's sleep, there's mood, there's alcohol use, there's lack of routine, there's physical activity, there's stress, there's managing your medication. Just to pop out a few of these that make a huge difference. Most older adults with any cognitive impairment are not taking their medications correctly. So your family member who's living alone is probably not taking their medications correctly. It's not their fault, but to get people on track, you see them next visit feeling better, more energy, thinking better, right? That alone. Then there's all these other things you all know. But to take the time to give personalized recommendations on things for people that you can tell are impacted by these, just like the Pointer trial, they are thinking better after you address those things, right? And so concurrently, we're doing maybe the Alzheimer's workup and biomarkers, but then you're getting buy-in too because they're already getting benefit. And couldn't we all, when we turn 55, get more excited about a brain tune-up than like your Alzheimer's screening? Yes, right. And so we talk about, this is another one, so goal setting, goal attainment for the person and dyad specifically. Like, what is important to you in your life? What do you want to be doing? And continuing to track and monitor those things. And again, great job for a young person to stay on top of that and follow up. Then lifestyle and resilience. I think resilience that's something I'm talking more and more about. Reframing challenging life experiences and adversities as opportunities for growth and transformation, and how reminding these people that no, they're not just a person with Alzheimer's and memory loss and limited function. Like, they've been a badass their whole life, and like they can still do that. Okay, so then diagnosis and recommendations. Within that all. So then just the care partner is focused on, similarly the mental health and well-being in a different angle that we take, and also in talking about their lifestyle and how they're going to give themselves give them permission to take a break when they're, you probably know this, a lot of care partners, even if they're out of the house, they don't take a break and they're continually stressed. And so not blaming them, because that makes sense. But how do you allow yourself to actually get respite is important. So there's a lot that goes into that. And then, so we're trying things out. This is proof of concept. We have a recreational therapist, we have OT consultation, we have the Resilient Care Partner Training Program. We have, I just am including a personal trainer consultation. A lot of people say, okay, well, I'm kind of like, I don't know how to use weights, and I don't just totally get it. Like, so this person can do like a really nice consultation and give them recommendations and sends them videos. He works with older adults, so he knows, what they need. And then just with the care partner, exploring mindset, grief, ambiguous loss, identity, and role change. And then I can, I'll prescribe medications if needed. No one really has, I haven't needed to do that at this point, but, it's probably in the water anyway. Like, we probably have one of these antidepressants in our water supply. So I probably don't need to. But I think the point is here is, because I personally have an interest in grief and working with that, I don't expect neurologists to, but what we need to, what these specialists need to do is know the value of that and have a team member that is an expert in that. And then the team member says, so maybe that's the brain health navigator, advisor, says, okay, I think this person needs to do this, like read, the Pauline Boss book, Loving a Person, Someone with Dementia, and do the ambiguous loss like work, and so the neurologist can reiterate that. And we talked, so Ron and I, wow, we got through a lot in 5 minutes. So yeah, just, it means something different when your physician says it sometimes, right? But then maybe not, maybe you can't stand the guy. But still, like, if you keep hearing it from multiple people, and now that I'm a business owner, I know that I have to ask 5 times before someone agrees to, like, work with me or collaborate with me. So we have to keep asking, and that's okay. And also, our patients have memory loss, so they might actually not remember that you told them. So what we've learned, I went through a lot of this already, but I would just say that, so I'm calling myself a professional nudger, and I'm lucky I'm able to do that. But what I'm doing is trying to find a model for, like, when and where and how does the specialist nudge, because they can't be doing that all the time. And, like, what are the team members and the roles, and how can we bring that all together in a way that, using AI and tech, that is clear and connected to the whole care unit. All right, I'm almost done, I swear. Okay, so how can we, thinking about this in rural areas, we did talk a lot about this already. So there's limited access to specialists. So a dyad-based model reduces the need for multiple referrals, minimizes care fragmentation. We have demographic alignment. So people here, right, aren't, they're staying in the house longer. And that from the get-go that your person is going to be living at home, and so earlier on you're getting those support services, and that changes the trajectory of the whole experience when you're learning from Rachel Wiley, like, better communication skills and how to not, correct and rationalize, but also not how to baby someone, or, that's not finding that balance, or at least getting those ideas and then seeing that modeled makes a huge difference. Leveraging existing community assets, community health workers, I think, I'm connecting with them in Arizona to see how we can create these in different, have brain health hubs, like say in Tucson, Flagstaff, and Yuma. And I'm sure that would go over well here. And then telehealth, I don't know how much you're using that, but I'm finding my patients since COVID, like, everyone is, good with telehealth, and you can do groups and all sorts of things. Partnership potential with trusted local institutions, libraries, senior centers, cooperative extensions. So it's really building those systems and monitoring those systems to make sure they stay high quality. So
Can I ask a silly question? How's
Sure.
it paid for?
So my practice is private pay, yeah. And so what I'm saying is, what this non-medical care, this is of high value, and what the benefit it's bringing to patients and families is worth that. Yeah, and so to demonstrate that, and the goal is that eventually it would be paid for by insurers. Detect early, personalize deeply, treat the biology and the human experience, continuous care, not episodic visits. So the dyad is the unit of care, and that's a big major challenge in our individualistic society. And so thinking about how that can be done, I imagine here there's more couples who see the same primary care provider maybe than where I am in Phoenix, but how can you connect people if they're seeing different professionals? How can there be maybe one point person who's like getting the information of both of them? Technology extends human connection, not replaces it, and then this is designed for equity, dignity, and possibility. Yeah, so ultimately, the goal is to transform the old narrative on Alzheimer's and aging, that there's nothing we can do, it's all about decline, it's all tragedy, and flipping that to, well, we need clarity on what's going on, we need to adapt to these changes together, and we can grow and thrive. So that is it. Thank you. I'm not taking questions now, am I?
Liz, I think there's time.
Yeah.
Do you want to help facilitate questions?
Or Rachel. Actually, I think it was Rachel.
Yes.
I'm happy to.
Okay.
You're already a rock star.
Yeah.
So are. You guys have to remind me, is it this microphone that we can use for the audience? Is this one connected to live stream? I wonder if you're good with one. Oh, might be good about it.
Oh, it's on the other side of that. Nope, I'm not putting it on.
Thank you. All right. What questions do we have? Here. All right. Is this working? We want to make sure the live stream can hear our questions.
Thank you.
Of course.
Well, first I want to say I really love your logo, and I hope somewhere on your website it talks about that, because being from Arizona, that's probably a good story. I also just really have a comment, and I think when people ask about how we're going to pay for this, we don't ask how women are paying for taking all the caregiving they're doing, and so that conversation needs to become more holistic.
Thank you. Absolutely.
Okay. Sorry. This could be a broad question. How do you, actually I can, so I'm a case manager and I deal with a lot of different clients throughout the day, and I run into clients who may not have a dementia diagnosis, but are experiencing cognitive decline. Do you have any suggestions on how to support people that are also dealing with mental health on top of cognitive decline? Because I like your, I like your model here where you're dealing with dementia through the science and also through the important social components to touch, as you would call it. So it's harder for my client to get involved with the social connections because of their mental health. So I don't know if you've experienced that throughout your studies or your, just being a clinician.
Yeah.
Like how to access that or not access it, but something that may have worked for them, like to get them connected.
The first thing I'd be curious about is, do they have anyone in their life that's supporting them and helping them apart from you? Or you're the guy?
She has a sister-in-law who plays the role of advocate that I'm thinking about seeing if she would do guardianship for this person. That's one of the main people in her life. She has a few relatives in Massachusetts that are in and out of her life. But one of her main connections is our social service agency. That's a lot of the connections that she gets, or, sometimes going out in the community and talking to different people, but there's also this aspect of she can only do this on her terms and for so long and so much.
And it sounds like I'm inferring that you're concerned she has, say, the beginnings of Alzheimer's disease, is that?
Yeah, I feel like it's, she's done brain scans and things like that show, they say, oh, well, it's the normal, she's showing normal signs of age progression, but for her, it's exacerbated because of her mental health. So I feel like she really needs to touch part of this therapy to help her improve. And it's just trying to find ways for her to achieve that I'm having trouble with.
Yeah. It's a big problem. It, to me, seems like there need to be systems that are built that this just doesn't rely on you only. And even spreading the net to other agencies that, like the Area Agency on Aging, for example, Alzheimer's Association, getting individuals or groups from there who are on board with her and what's going on, and then with her doctor or healthcare professional, having them do a brain tune-up, sort of. So they call it a memory evaluation. And as much as you can, and you're able to accompany her to that, and if she's afraid to, or she doesn't, she's intimidated by that, I usually say there's so many reasons we can have cognitive changes as we age, and there's some of them are really easy to fix, and you're getting this evaluation, they can help with that and get you feeling better and thinking better now. But in the meantime, spreading the net as much as possible. And I hope that, and it sounds like in this group here, especially your leaders, and looking at what are new systems that can exist, that there can be more touch points and not losing her. Whether or not, with the mental health issues that, and I'm not sure exactly, that could be a number of things, that adds a whole other element. And if she's living alone. So you have a lot on you right now that I think you need other agencies. And I actually welcome other people to help answer that question that may be dealing with.
I know it's a very broad and kind of weird.
No, I think that's actually common. People living alone are in a most tough position with aging. So, and getting, these things like sleep, med management, all these things addressed earlier can change the trajectory of their lives. And so I think everyone should get automated pill dispensers. I tell all my patients that these are like very affordable now. For example, like that could be a game changer, honestly. So stuff.
Getting the med consistency going, and because of her mental health, her caloric intake is also not up to par, which if you don't have that, then the meds don't work as well.
She's really lucky to have you.
Thank you for that. How are we timing-wise in terms of questions?
Yeah, I think we can have 2 more questions.
Okay, thank you.
I have 2 questions or comments. I think that the number of people is way lower. The number of people who have some type of dementia is much lower than reported. I think there are a lot of undiagnosed people in the communities, especially more rural, spread out communities. We also have a dearth of neurologists in the Northeast Kingdom. The closest one is more than an hour away, and people don't have a vehicle. So I think that the number of, was it close to 13,000? That's low.
Too low, yeah.
Yeah. And then the second thing, I wondered if there was any particular research that is being done on people with early onset Alzheimer's disease. I know there's a lot of work that's been done in South America because of those genetic families. But I didn't know if you could comment about that population particularly.
There are studies being done at WashU in St. Louis through their Diane TU Dominantly Inherited Alzheimer's Network, and they are studying actually an anti-amyloid plus an anti-tau medication combination in individuals who have, it's presenilin 1, presenilin 2, or amyloid precursor protein mutations. And what I've heard, the preliminary data, is that people who are starting these, they're starting them before they have any symptoms and even before they have elevated amyloid. They may be 25 when they're starting these medications, and looking at over, it seems that people who should have developed symptoms by modeling, they're 8 years now with still no symptoms. So they had the add-on, the anti-tau added on relatively recently. That's a newer development, but for that group anyway, it does look promising.
And are those meds applicable to people with later onset
Yes.
Alzheimer's disease? Okay.
Yes, and it's essentially this early onset autosomal dominant young age presents an opportunity to see people who are going to progress much faster. And so while they're different than an 80-year-old, they can be translated broadly.
Great question. We can do one more question. This is kind of a branding question regarding the way that you mentioned high tech, high touch. It's great phrasing, and I love it. And this medical, non-medical issue is, I think, prevalent across all sorts of areas. And you looked at like ahead 10 years, ahead 20 years as we look at that division being different, right? Like we're going to have more medical access as these things get translated to practice. My question for you is, do you think that the branding strategy or the movement is going to be more getting insurers on board with covering non-medical, or getting them to consider some of these things as medical within the biopsychosocial model?
I think it's getting them to see the role of paying for non-medical. I don't think the powers that be will ever see spiritual, or grief work as within medical. And I think it's good to keep it separate. And I've thought about, why should Medicare pay for something like that? Or like, where does that end and other funding sources begin? So that's a great question. What do you think?
I'm getting my PhD in translational science, so this is actually very much up my alley, but it's a big question of like, how do we consider rephrasing and reframing in order to get buy-in, especially from an insurer, saying, no, this has a medical impact and therefore that's why we should care, versus the harder work of saying you should care about the whole person. And so that's kind of the basis for my question of like, when you're targeting that as you have a private practice, how are you going about saying, here's the high touch and here's where it fits into a more medical model versus that you added more biopsychosocial, relational, connection model?
Yeah, I'd love to keep that conversation going. And I would say something I've learned from people coming in is they don't want to talk about usually any of that non-medical until they have clarity on what's going on. And yes, this is a select group that's coming to me to get clarity. But when I brought up, I brought up rec therapy like too soon once, and they're like, I don't care about rec therapy. Like I want to know. And I was like, oh yeah, like good point. So that's another piece, is the timing.
I have a comment to just continue the conversation a little bit.
Yeah.
I work in primary prevention, and we need to change, I work in primary prevention, and we need to change the understanding of, if we do these things beforehand that are not necessarily medical, we don't get to a point where medical needs to intervene, right? And so I think we all intuitively know those things, but our healthcare system, or sick care system, that I like to say, we don't value it enough. And so how do we change the conversation that we're having socially and within our states and within the communities to put value, medical value, on primary prevention? I think that's where we can maybe make those kinds of efforts.
I'm glad you're working on that.
Thank you.
That's so important.
And thank you again so much,
Thank you.
Dr. Kroll. We really appreciate you.
While we get set up for the panel, I realize some of you may have had comments or questions that we have pieces of paper if you would like to write them down. If we don't get to your comments or questions today, what we'd like to do is reach back out. Any information we can provide related to what you're interested in and or build into our next symposium and education sessions next year. So if you would like, just help yourself to, I have a taker here. Just please help yourself to that. And panelists, you can start to come up.
Do we know how to put that screen up? Nice to meet you. Yeah. Thanks for that.
You want the screen up?
I hope not. Justice has a tendency to just manage everything, so anyway, yeah. No, it's good to be here. This is really interesting. Yeah. Yeah.
I went to the memory cafe.
Yeah. 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 I know. Yeah. So what corner are you? Are you in the back corner? I don't see Lexi, but she's probably back there. Yeah.
We have a great panel here for you, and we're so pleased that Liz McCarthy, who's the Regional Director for Healthcare Systems for the National Office of the Alzheimer's Association is here to facilitate. She will introduce our panel. You will have a chance to ask questions. And what we're really exploring is more of what Dr. Cabral shared with us of what care looks like in Vermont and what can we imagine for it to look like. So thank you, Liz.
Oh, sure. Thank you. It looks like there are still a lot of people who are not in the room. But I will say that this, when I was sitting over here listening to Dr. Cabral, and it looked to me like church, or so everybody is in the back and in the corners, and the panel, we don't have slides. It's going to be Q&A. So if you wanted to move into the center so you can hear better, you can do that now. And of course, no one did that. So not to delay too much longer while people are coming in, I will introduce our panel. I'm going to start from my left on the far, where am I? Yes. On your far left is Dr. Richard Orland. We're so happy he's here. He is the lead physician for the Community Health Center in Rutland. Did I get that right? So?
For the geriatric service line.
For the lead physician for the geriatric service line. And I just discovered that he has to travel to Rutland from Putney, was it? So, yeah. Yeah, okay. I'm getting things half right so far. I'm failing as a moderator, but would you like to introduce yourself, sir? Okay. Next to him, we have Kristen Bolton, the Executive Director of Elderly Services in Middlebury, Vermont. Did I get that right? How did I do that?
Doing perfect.
Okay. If I botch Christina Haygood, who is the nurse practitioner at the University of Vermont Medical Center Memory Center, because I've been on like 40 meetings with her in the last
You
month.
got the last name correct. Thank you.
Okay. How about the rest of it?
Yes, nurse practitioner in the memory program, UVM Health Center.
Okay, perfect. Brenda and I have also been on maybe not 40 Zooms, but several Zooms with Brendan. Brendan is also a nurse practitioner and is the principal for Full Circle Medicine, a primary care practice that does primary care at home, based in Heinsberg.
You got it.
Okay, all right. I don't know if I can say much more about Dr. Danny Cabral. So, love that you spent some time in New England, though, that you're not just Southwest. So,
I grew up in Massachusetts.
Oh, you did?
I know, I didn't mention it. I should have.
Yeah, where?
Webster.
Webster. All right.
Yeah.
That's in Central Mass. I'm also from there. Sorry. I just so that the car that you see with the Mass plates out there, it's mine. So don't be mean. And then Mark. I'm sorry, Mark. How are you?
How am I?
How are you?
Thanks.
Excellent. Mark is the Executive Director for Senior Solutions Council on Aging, covering Southeastern Vermont. How'd I do? Accurate?
Yes, that's Southeastern Vermont, Council on Aging, yes.
Okay, so one more pass. Anybody coming back in, you can sit towards the middle or towards the front. First, I'm going to ask a question of the entire panel, so it'll be the same two questions for each of you. And we'll start here with Dr. Orland on the end, go to the end, and then we'll give it to Mark and come back the other way. So Dr. Orland, if you could start, describe your role in the care of people living with dementia.
I can't remember. So first I have to say I'm not aging, I'm fermenting. So if there's a question. So I consider myself a born-again geriatrician. I actually am a biochemical pharmacologist who started in internal medicine, became a critical care-based nephrologist, and then woke up and realized that most of the people I was taking care of didn't know I was there, and they needed extra help and nobody else was caring about it. So I actually moved to Tampa Bay, got on board of the Alzheimer's Association down there in the early 21st century. And I started doing geriatric care with for-profit, not-for-profit, faith-based, and different settings. So what I learned was no matter where you are, that you can take care of older people if you have a team, right? And that someone has to ask the question, what did you have for dinner last night? And if you can't remember that, that's a good start. I don't care, you don't have to have a diagnosis, but it's eventually going to be important if you want treatment. But you have to start the conversation, and you have to start it early, which is part of what we heard this morning. And what we're hoping to do in Rutland, and we continue to do, is to screen people early, and to listen to them and their families, so that when they present, they have a question or a problem, maybe we can be there to help.
Brilliant.
Does that help?
Yeah, thank you.
All right.
Thank you very much. So the same question to you, Kristen, and I can repeat it. Describe your role in the care of people living with cognitive impairment. What were your other terms, Danny, that you used? Did not say dementia?
I use cognitive functional impairment.
Okay, so with cognitive functional impairment.
As the Director of Elderly Services, our primary program is an adult day program. Have you all heard of Adult Day? Yes. So I like to tell people it's like a school for older people, and it provides a community for people living with dementia as well as their caregivers. So we work with people who are in our center, and we give people who are their caregivers the guilty pleasure of being able to have time to themselves. And within our center, we provide a community approach. It's a mainstreamed community, so not everyone has cognitive functional impairment. Some people are lonely because they lost a spouse. Some people are lonely because they're 93 and all their friends have died. Some people have had strokes, so it's very much a very diverse community of people with various abilities and disabilities. And we provide a fun-filled day, joyful connection, spiritual connection, and the caregiver also gets to enjoy the benefits of this because their loved one is really happy when they leave. And so not only has the caregiver had time for themselves, but they have a happy person to help at home, so they've had a break. We're also a very affordable alternative to institutionalized setting and to one-on-one care. And so we had the benefit of that community setting, which prevents isolation and loneliness. And then we are affordable because it's a lot less expensive than paying $35 to $40 an hour for someone to come into the home and really still keep more of an isolated aspect. Some of the stigma you talk about, I feel like, can dissolve with participating in a community.
Do you want to repeat the question, Christina?
I think I got it.
Okay, awesome.
Thank you. So I'm a nurse practitioner with the Memory Program. I was brought on through the BOLD grant about a year and a half ago to join the Memory Program as to implement the Vermont Alzheimer's and Dementia Care Program, which is based on the UCLA pilot or the UCLA ADC Alzheimer's Dementia Care Program. So this was a pilot, and it really is focused on working with the dyad, focusing on caregivers, connecting them with support resources, and a lot of just meeting with caregivers and trying to be somebody who they can relate to and they can get advice from. So we wrapped that up. I'm now in a more permanent position with the Memory Program, thank goodness. And we're working with the VADC now to try to take some of the lessons that I learned from the pilot program and try to change the way things are done in Vermont.
My name is Brendan Conroy. I'm also a nurse practitioner. I opened a practice about a year and a half ago called Full Circle Medicine, providing in-home primary care to individuals, primarily folks living with dementia. Really with the reason for the practice was seeing this gap in care for people, especially with moderate to late stage dementia, who just getting out to a primary care office is such a challenge, especially if they are not feeling well. It's stressful for their caregivers, and also just overwhelming. And also that traditional primary care visits lasting 15 or 20 minutes just do not work for somebody with a cognitive impairment. It really takes a lot more time to, you know, be able to spend the time with them, maybe spend some one-on-one time out of the room with the caregiver, evaluating the home setup. And so that was sort of the impetus for the practice. And so it is primary care, but primary care specifically for folks living with dementia.
Thank you for all of what you all do. Wow, that's great. You already heard about me.
I'm Mark Boutwell. I'm the Executive Director of Senior Solutions, as you saw up there. It's the Area Agency on Aging in southeastern Vermont. My role, well, I will speak for all the area agencies on aging. There are 5 area agencies on aging in Vermont, and the agencies on aging are stipulated under the Federal Older Americans Act. So each state gets funding and has a plan under the Older Americans Act, and Vermont administers that plan through independent, not-for-profit agencies on aging. So we cover 46 towns throughout southeastern Vermont, largely Windsor and Windham counties, but also Orange and Bennington counties. So under the Older Americans Act, we are actually stipulated to provide caregiver services, and there's funding attached to that. So we have to first of all, we have to provide those services, and we have to account for them. And second of all, of course, it's so important that we do that under the Older Americans Act. And you know, we give priority, and when we think about the services we provide, we prioritize caregiver services and do things to reach out to caregivers so that they know where those services are available and who we are and how they can reach us. And again, one of the roles that we play through the state, through Dale, is that there's funding attached to these services. So we just heard about the adult day centers, and we administer funding stream that can support people attending adult day centers. And we also administer funding through the Older Americans Act that supports senior centers. So we have ways, both directly and indirectly, to support these services throughout the state. And again, pretty much anywhere you go in the state, you will be able to receive the same level and quality of services through the agencies on aging and the programs that we support.
Thank you. And so keep that microphone, Mark, because I'm going to, you're number 1 for the next question. What does dementia-capable care look like to you?
Dementia-capable care, it really, well, I think for me personally and the agency I run, which really speaks to a lot of your comments, and particularly if you know Vermont, you think about the Northeast Kingdom and also Windham County are extremely rural. So dementia-capable care means finding ways to reach out to caregivers and their loved ones in those rural areas. And it's a challenge. It's a challenge for people to get to services. And so, again, we try to find ways to reach out to them. We have outreach workers, we have case managers, and so we have a number of ways we make services available to folks with dementia and cognitive decline. One of the things that I'm really excited about that Senior Solutions provides is we have 4 different sites in which we do memory cafes. And so these are monthly events where care partners and their loved ones can come together and There are activities for the person living with cognitive decline, and there's also peer support for the care partners. And we've seen really a lot of success with that model. People, typically caregivers, rightly so, are reluctant to, even when they have respite, to leave their loved one at home. And if we can provide a setting in which they can come together and both have enriching activities or engagement, that's what we want to do. So that's one of the areas that we're really excited about. The other area throughout the state is an online caregiver platform called True Alta. And again, at any of the agencies on aging, it's something that we pay to subscribe to, and then we make it available to caregivers. And it's one of those platforms that you can go on 24/7 in the middle of the night if you're up and you need some tips on how to deal with sundowning or some other challenging issue. You can log into this platform and get some educational tips, whether they're 3 minutes long or half an hour long. So that's something that we're very excited about making available. Certainly we have respite funding and support that we provide. So people come to us and we can provide funding for them to purchase respite so they can get out of the house. Obviously information and referral, and the other service that we provide, again, throughout the state, is something called options counseling. So families, care partners can come to us and get counseling about what their options are, what long-term care facilities are available, where they should turn for estate planning, things like that, that really support them in decision-making for themselves and their loved one. And then, of course, we do provide case management, and part of that certainly is helping people get connected or stay connected with their primary care physicians or make neurology appointments or things like that, so that they're getting the medical care that they need. So those are a few of the ways that we are practicing capable dementia care.
That's amazing. Thank you. So, Dr. Cabral.
I'm going to take it in a slightly different direction. I think about any environment or group of people or person that can see someone or a family who's facing one of these diseases and is compelled to look deeper at what's there or could be happening. And so from a positive perspective, I mean, so I have a 5-year-old and she has this book called Look Again, that, you open it and it's like a cat, but then you spread out the page and it's like this beautiful scenery with probably rainbows and unicorns. But I think that like all of us know that there's more there, but it's up to us, it's relational, to help bring that out for that person who used to do it for themselves. And I love, and I think of this kind of space where you don't know what you're walking into and you're fine with that. Like, I walk in a room and I'm like, could be 1980, could be 2000, could be 1960, I don't know, it doesn't matter. Like, what year is it? How old are you? What's going on? And you can flow with that and know that, like, being fixed and rigid isn't better. It's not better if we're in the actually 2025 for that person, and how to see and be open that something even more amazing could come out of it if you're present with that person. Sorry, that was like up there in the clouds, my answer.
So when I think about it, I definitely agree with what's already been said. It's this very holistic approach. When I think specifically about our state and our region, and what some areas that we could focus on, especially from a kind of a clinical perspective, is empowering primary care, really, to feel more comfortable caring for individuals, diagnosing individuals with dementia, supporting families, because the reality is the memory center is amazing, but they are limited in the number of people that they can take. And so often it falls to primary care to be the ones managing all of it. And it's a lot to manage. And so how do we support primary care? These individuals who are already so taxed and have such a limited ability to spend time with people, how do we support them as a state to, allow them to care for people with dementia and their loved ones? And also I look at, our hospital system and kind of all of the pieces and parts, because individuals with dementia have many touch points in the healthcare system. It's not just primary care. They're going up for an ultrasound, they're going to x-ray, they're in the ER, and how do we make sure that these people are supported in all of those areas? I had a patient go up for an ultrasound to rule out a DVT, a blood clot in her leg, the other day. The person performing the test did not know that she had dementia, so thought she was just sort of this agitated and, unwieldy person, and so became quite agitated back with her. This person didn't know, they did not know that she had dementia. The care partner did not know how to navigate this. And that's just, one scenario that happens a million times a day, right? Is these people are kind of thrust out into the medical world, and, the medical world doesn't always, A, know that they have a diagnosis of dementia, or B, know how to navigate that. And so how do we, collectively come up with a better system and a better way to make sure that people are knowing about somebody's diagnosis and also supporting them in all of the different ways that they navigate with the healthcare system.
Dementia capable. So I think that, as Dr. Cabral mentioned in her wonderful presentation, there's a lot that goes into the barriers. What are the barriers that prevent us from really enforcing, developing dementia capable care? And I think that stigma is one of the most significant factors. I work with a lot of folks who are just incredible people, and once they receive their diagnosis of dementia, it really is this tragedy that happens to them. And I try to talk to them about all of the people that I work with who, you continue to live a wonderful life that's full of joy and full of meaning and full of connection. But there is still this underlying stigma. Also working with folks who are mourning, they're diagnosed with dementia and they're mourning the loss of their family structure as they knew it, which is contributing to mood symptoms, behavioral symptoms, because the grandkids don't know how to interact with them anymore. And so the grandkids are afraid and they're staying away. And so there's this loss of connection, and I think that connection is another big piece of dementia-capable care. And it's not just connecting care providers and systems, agencies on aging and providers, and all of the different systems that go into supporting dementia and the caregivers. It also goes into just the lack of connection that we have as a society, and how isolated a lot of folks are, and how much that leads to a delay in recognizing the symptoms, a delay in recognizing and getting a diagnosis and getting treatment and getting connection to the services. So it's a lot to do with really difficult challenges like reducing stigma as a society with aging, but also doing a better job of connecting professionals and connecting individuals within the community.
Thank you. Well, it's great to have all these perspectives. I'll share the perspective of someone who works with a wonderful team of people to care for about 125 people. About 75% of them are living with cognitive loss or dementia. And so I was thinking dementia-capable care is how do you work with the person who's right in front of you, who's wondering when her mom's going to pick her up, or in half an hour wondering where the kids are, and she's not talking about her adult daughter who's going to be there in half an hour. She's talking about her little kids. And So I feel that dementia-capable care is highly individualized. Every person experiences this differently. And it's very improvisational in the way that Dr. Herb Cabral talked about it. I really feel like I've been trained in improv some days. You just go with it. You're not going to tell the woman who's looking for her mother that she died 20 years ago. I think you all know that. But how do you help her get regulated? Because what she's really experiencing is this dysregulation, and it's very dysregulating to have dementia, even if you're more clear-minded. Why are things not making sense, and where am I? And so it's both an individualized approach, and building relationships for us is really how we address dementia. Medication, sure, you want to make sure the meds are on track. We have registered nurses. Social workers to help the family so that issues at home are more manageable, but day-to-day, moment-to-moment, how do you help this person become regulated? It's the relationship. You develop a deep and trusting relationship based on mutual respect. So you have to really love the person in front of you who's looking for her kids and is holding on to the teddy bear. I mean, not all of them are. Another man might be falling asleep, or he doesn't want to engage in anything. How do you help him be himself? We're kind of valuing the human spirit. How do we help people still be the person they are in spite of or with the changes that this disease brings to them? So that's what dementia-capable care looks like. And it doesn't just happen one-on-one. It happens in community. People helping each other, another person holding this woman's hand who's feeling a little fraught. And then they have a purpose. They can help other people. So there's a real richness to this that is where the joy is. It's not easy. I'm not saying it. It's not tragic, but there can be joy, and it's through the relationships and connections.
Wow, it's been many years since I've been in cleanup better. So it's hard when you have the attention span of a flea to stay on focus, but I wanted to try to close this out with a couple of thoughts. One is, I wear many hats in my semi-retirement. You tell if I've lacked a hair of greatness. That as a hospice medical director, that the GUIDE program maybe will be similar to the Medicare hospice benefit in the sense that it is more than just the medical care of the person who's going through the active part of dying. It's the family care, it's the support, it's the post-loss care that makes the hospice medical benefit work. Well, why can't the GUIDE program be that? And I'll circle back to that in 1 minute. So let me just give you the 411 on the community health centers of the Rutland region, because I don't know if everybody knows what we do. We're the largest provider of primary care services in Rutland County and its environs. We have multiple freestanding primary care centers that take care of people from literally the cradle to the grave. And we have specialty services that include dentistry, eye care. It's all funded through a federally qualified health center. It is a unique medical model. So what that allows us to do is to really get people through their aging continuum, through their medical traumas and stresses, and identify them. So how's that dementia capable? Find the triggers, see the triggers, identify when people are at risk, and then throw everything you got at them. And the beauty of our system is we have case managers. We have a team of case managers built into our primary care program. Where do you have that? We have a robust behavioral health component. So while mental health is obviously a very important problem when you have dual eligible and dual diagnosed people as your primary clients in many cases, we have a capability of really seeing people across the whole spectrum. It's wonderful. So another hat I wear. There's a company called Isaac Health. Have you heard of it?
Yes.
It's a web-based, one of the 40 GUIDE providers that's out there, and is taking care of people across the country with dementia and dementia-related disorders. As the medical provider that works with them, I'm doing their medical evaluations virtually. It is cool, all right? I'm pretty old, and I've been doing this a long time. I would never think that I could sit in front of somebody after they've had an adequate neuropsychological evaluation and a close to at least a primary diagnosis, hopefully after the right imaging, which is right in-house. And I mean, I could sit in someone and feel comfortable saying, hey, we gotta talk. There's some stuff that we may be able to do, there's some stuff we may not be able to do, and these are all the things in your community, if we get all that resource managed, that we're gonna be able to do for you. So it's terra firma, but now it's also virtual. And this is the only way we're gonna fix this problem. That's my circle back.
Hold on to that, because I'm going to come back to you. I'm going to ask each panel member now a question designed just for them. But thanks for all that. I thought that was really great, coming from each person's area of expertise. So, Dr. Orland, for you, the question is, describe what dementia care looks like in Rutland. How are assessments and diagnosis managed, and is there a defined clinical pathway?
I can't use bad words, right?
Well, so it's a challenge, right? Because how many neurologists are there in Rutland now? Zero. So it's literally, did someone buy something on Amazon? Is that okay. Yeah. So, and again, Rutland is it's a tough town. There's a lot of stuff that's going on, and without having someone to help you with movement disorders, with seizures, with everything else that goes along, how the heck are we going to take care of dementia? So it then falls on primary care providers to do the screening. Well, wouldn't it be nice if our annual Medicare wellness visits were being done? At least you'd have a screen. Well, I'm here to tell you we need to work on that. So there's a lot of opportunities that then therefore are missed. So what are we doing hopefully in January? We're actually setting up a geriatric assessment program. And what we're going to do is get people identified in our primary care program, hopefully, people that are getting discharged out of the nursing home and can't get to their doctors quick enough and maybe they have a diagnosis, and other people at risk within our practice, and say, hey, let's see, can we get closer to a diagnosis? Can we set up their imaging? Can we get a metabolic study? Could we get infusion care? I mean, subcutaneous infusion is unbelievable. The problem is the numbers are going to tell us whether this all makes sense or not. And as a biochemical pharmacologist, that's the other hat, I'm going to tell you, I'm still suspect of all this stuff. So I'm from the show me state, Brooklyn. So dementia care in Rutland, we have opportunities.
Okay.
I'm working on my, my evening shtick too, so.
Kristen, what innovations has your day center developed to improve care or access for rural individuals living with dementia?
I think adult day is still an innovation. So it's underutilized. There's 11 centers in the state, and I see some of my colleagues here. And so it's affordable, it's engaging to people, it gives caregivers time. They don't have to navigate the doctor's appointment. They don't have to navigate something on their phone when they've got someone putting their underwear in the freezer at home. They really, it meets them where they need relief. So I just put that out there, that all adult days provide that level of support, as well as actual support for the caregivers, aside from attention and love and devotion to the person living with dementia. Our center we're all unique, so our center is doing a couple of things additionally. One is we've started doing a loneliness assessment based on the UCLA questions, and we're finding a real significant difference, statistically significant difference in the loneliness of the participants. Yeah, wow, there we go. 2 points for me. So people are less lonely coming to our center. We're also doing substance use screening to see if there's a connection between a way that we can help mitigate substance use with the people we serve, as well as the caregivers. And then we're situated in Addison County. There's no adult day in Rutland, as you're very aware, which is a tragedy. And we are not a senior center. We're like a senior center on steroids, maybe, because we provide that additional level of care. And then there's a very small adult day program in Burlington, which you can imagine would not meet the needs with 22 spots available. And so we are providing some transportation from Burlington, and just got a grant from VTrans to enhance that program in Burlington and also provide transportation from Rutland. So my staff are like, really? We're going to find drivers to do this? But yes, we are. And talk to the communities about the fact that we can provide those services. So that's another innovation. And actually, another innovation we have, I'm looking right at Lexi, who's one of my staff. We're going to be implementing a gardening and composting program to provide that level of hands-on engagement. So our therapeutic activities program is alive and well. And if you want to talk to Lexi more about that, you want to just raise your hand up there. So composting, who knew? Okay, I'll pass it along.
So Christina, my question for you is, what would help the Memory Center advance cross-collaborative care across the state?
I think that's definitely something we have been working towards. We have implemented some programs for enhanced referrals to provide consultations with primary care providers who are doing the diagnosis and maybe need a little bit of more guidance in terms of getting a more accurate diagnosis, or if there are symptoms that aren't responding to traditional treatments. Being able to provide recommendations for better diagnosis, more accurate diagnosis and treatment for individuals. And then there was also an attempt in the past for one of our neurologists to actually have a designated, I think it was a half day a week, where he just had open office hours, essentially. So anybody could, any provider in the community who wanted to consult had the opportunity to do it. These have been poorly utilized. We're not getting very many enhanced referrals, and we stopped doing the half day a week because the neurologist was hardly getting anybody. Yeah. I have worked as a nurse practitioner in 2 states, and I don't think that this is a problem that is exclusive to Vermont, but we are getting much more into a refer mode. And I say this with a lot of empathy and compassion, because I did start my career in geriatric internal medicine as a primary care provider before going into specialty. And I certainly understand the demands that primary care providers are under. And giving them one more thing that is very, very time consuming when their system isn't set up in place to be able to meet the demands. Really do a thorough history and physical for folks who present with memory concerns. But we do need to be better about screening in the community and helping to release the pressure valve on the memory program, I think, so that we can start to develop some additional programs, because there is, it's myself, another nurse practitioner, and 2 neurologists in terms of, diagnosis and management. And one of those neurologists is approaching retirement. And so I think that if we can get our heads above water, then that would be a good first step. But also, I'm working hopefully with the VADC, the Vermont Alzheimer's and Dementia Care Program, to really help promote some of the tools that we have established, such as the enhanced referrals, making sure that providers around the state are aware that, yes, you can go ahead, start the screening, start the workup, get the diagnosis, use this if you are needing more assistance. We've also created a dot phrase that I'll talk about later this afternoon that is within the EPIC. Anybody who's using EPIC, we can give permission to use this dot phrase, which was created to help PCPs better diagnose. Basically, it's dot dementia DX, and it populates a set of questions diagnostic workup recommendations, connection service recommendations. This was created, I think, 2 or 3 years ago, never used. So we are working, hopefully, through the BOLD grant and the VADC program, I will be working to better promote some of these services and see if we can actually get people using them, get some feedback on how to better tailor them, and that's, I think, a place to start.
Yeah. Before we go on, although you can give Brendan the microphone, because I was going to ask, we have 2 primary care providers here, Dr. Orlin, geriatrician, and Brendan. Is what Christina's talking about, is that helpful? Is this sounding like something you could utilize, or barriers to utilizing it, or?
I mean, I think definitely. It sounds very helpful. I think my practice in particular is a little bit unique because I'm mostly getting people referred to me once they already have a diagnosis, and it tends to be more moderate and late stage dementia that I'm taking on, and so I'm more kind of helping families with that portion of the journey. So you might be able to speak more towards kind of the diagnostic component and how that would be helpful for your
That's
practice.
what we're trying to do by setting up an assessment program, is to get people in, get them early, get them referred if they need to, or even start getting them access to treatment if we can.
Yeah, yeah.
Thank you. Okay, Brendan, now you get an actual question. What policy or reimbursement changes would make in-home dementia care more sustainable?
I think reimbursement is the biggest component there. You know, you have to factor in the fact that we are a rural state, so you are traveling. There is a lot of car time in between each visit. And as much as I try to manage my schedule where I'm not driving from, Ripton to Burlington in one day and then back down to Virgins, it happens because all of a sudden you have an acute visit and you gotta rework your day. And when you're spending that much time in the car, it's not reimbursable. And, try to make phone calls in the car, et cetera. But, there has to be, factoring in a way to either consolidate the radius of in-home providers or look at, some telehealth, although that's good for certain fragments or certain things that come up, but there is so much to be gained from seeing people in person and seeing them in the home and seeing what's really happening there, because on the phone and in that screen, things look great. And then you get to the home and you see the stacks of bills and you see that there's no food in the fridge and you can see the reality of what's happening. So, Medicare reimbursing for a 15-minute visit, for, 45 minutes round trip in the car and an hour plus, seeing that person going through everything, hearing about their cat, talking to their daughter who lives in California. It's just, there's a lot of components to it. And inherently when you're doing, in-home, even if it's primary care, you're playing multiple hats. You're wearing the social worker hat. You're going to connect them with resources kind of in the moment. You don't have a team sitting outside where you can be like, hey, medical assistant, come in here and do this EKG for me. Hey, social worker, come in here and talk to them about resources. It's kind of all one person, which is fine. But again, then if you're trying to reimburse one provider for all of those roles, reimbursement has to look very different for that.
Thank you.
Mm-hmm.
Okay, next question. I had to change it after seeing your presentation. So GUIDE, as you know, it's a demonstration. It's a pilot demonstration model. Do you, with Brain Love, have a plan to work with ACOs or insurers to get them to carve out and pay for a model? And this, Brendan, it could even potentially apply to what you're doing to get insurances to pay for it, for what you're doing.
At the moment, I'm not doing that. It's not possible to both do what I'm doing and connect directly with Medicare GUIDE providers. I can recommend GUIDE programs to my patients that they can then seek out. And in full disclosure, having now lived in the world long enough to see that you can research something for 15 years and show positive studies over and over again, and Medicare may pay for it a measly amount, and yet so many other things that are in pop culture do get paid for by payers that don't have any data. I'm going with the seeing real people have positive effects, and then studying this in ways I can, getting local funding and larger funding too as time's going by. So that's my answer to that, I guess. Yeah.
And then Mark, as one of 5 AAAs in the state, please describe how you partner with other organizations to provide dementia-capable care for rural residents.
Sure. So first of all, again, I spoke earlier about the Older Americans Act and how that guides a lot of what agencies on aging do. And you can think of agencies on aging as providing services like case management and our helpline. But one of the primary principles or tenets of the Older Americans Act is that agencies on aging function as hubs of networking and building out supports within a community. And personally, for me, that's one of the most exciting aspects of what I do, is to work with a lot of organizations, a lot of, we actually are fortunate, we have 3 adult day centers in our service area. So I get to work with them. We have senior centers, meal sites. So I do a lot of work just out in the community with hospitals and a variety of organizations, talking about what we do, talking about the needs of older Vermonters with cognitive decline or not. And so again, personally for me, that's something I really love doing. And if you look at my calendar, it's just full of meetings all over the place. But making those connections and really, I guess it's maybe I blame my father, who was a minister, that I think of this as my ministry, that I'm out really preaching sorry to get religious, preaching the gospel of aging in Vermont and supporting aging individuals and their caregivers. So that's just me personally, and again, part of what's baked into agencies on aging. I want to tell you that we have a terrific relationship with Dartmouth Hitchcock and Dartmouth College and the Dartmouth Aging Resource Center. And I'll make a shameless promotion here that the keynote speaker for my annual meeting next month is Dr. Serena Chow, and she's a nationally respected geriatrician and medical educator dedicated to improving the health and well-being of older adults. And she recently was appointed as the inaugural Chief of Geriatric Medicine at Dartmouth Hitchcock. So I'm really excited to, again, through my connections, to have this geriatrician come and be our keynote speaker. And actually, to just take this a step further, the topic that she's talking about is reducing ER visits in house calls patients with dementia. So she's talking about working with folks with dementia and doing house calls as a way to reduce ER visits. So that's one of the really exciting collaborations that I have. And again, also not just Dartmouth Hitchcock, but the Geisel School of Medicine. I have a board member who's a researcher with the school with Geisel School of Medicine. And we have a partnership with Dartmouth College in which professors will pick up a project and come and work with an agency. So we've had a couple of instances where college students come and work with folks in the adult day centers, work with folks in our memory cafes. A couple of years ago, we had, probably can't see this, but a team of 4 college seniors do art projects and build a collage with folks at our memory cafes. The other exciting collaboration I'll just say that we have is we have gotten grants from the Vermont Council on the Arts. And last year, with that grant, we bought sewing machines and we took them to the middle school in Springfield, and a group of middle schoolers sewed lap quilts out of various materials. So these were tactile, stimulating materials. So they spent the semester sewing these lap quilts, and then they came to our memory cafe and presented the lap quilts to the participants. It's going to make me choke up because it was so touching. And again, so it's so exciting because this is intergenerational. We're exposing these college students to folks with cognitive decline and their caregivers. We're exposing middle schoolers to folks with cognitive decline and their caregivers. To me, that's so important. Having just again worked in social services most of my career, it's so important that we let other people outside of our little bubble of profession know what we do, know the challenges and hardships that people encounter who are experiencing this. And so that's, again, for me, part of what I do in my ministry is get that word out there. We have so many, I have a long list here of collaborations that people we collaborate with. There's a hospice center in Brattleboro that we've done some work with. We work with the music center in Lebanon to bring a music therapist into our memory cafes. So that's a tremendously exciting collaboration that we have. I work with all the hospitals. There are 5 hospitals in my catchment area. I work with them and how to support folks with dementia who are coming into their hospitals. All sorts of, yeah. So lots of collaboration. I'm out there doing that every day.
Thank you. And will you be here for lunch if people want to look at your list?
I'm here all day.
Okay, awesome. So who is anybody here from the Upper Valley area? So it's okay. So you guys stole Serena Chow. She was at Cambridge Health Alliance, and I worked with her very closely on her house calls program, in which nurse practitioners went into the homes of frail elders within Greater Boston, typically underserved areas in Greater Boston. And she's amazing. So I'm so glad she's working with you. I miss her dearly in the Metro Boston area. Glad she went to Dartmouth and didn't completely desert me, like going to Arizona or something. But yeah, so that's terrific. I think we still have 15 minutes. So does anybody have questions for our panelists? Oh, lots of questions. Okay.
This is a. Oh yeah, I love a microphone. No. I mean, not that you want to hear. Thank you. This has been very interesting. My name is Helen Laban. I run the Vermont Healthcare Association, which represents residential long-term care providers. Forgive me for what is a very brass tacks question here. One thing that we look at is what is the capacity, especially in our rural nursing homes, to serve the increasing population of those with advanced dementia. It's not good, just FYI. It's not great. We do what we can. We're going to keep working on expanding that and providing high-quality care. One thing that I wonder when I look at timelines such as what was presented this morning in terms of new treatment innovations and new prevention innovations is, how long do we wait for a downstream effect on reducing some of that pressure on the capacity at the very furthest end of care and intensive care? Because
like I said, we're going to continue to work on it, but rural America really needs some reduction in that pressure on a very limited capacity.
Was that just one specific?
That was, anyone who wants to speculate on that, I would love to hear the answer.
Anybody have thoughts?
I can take a stab at it. So I think if I understand the question correctly, it is what can we be doing better to help alleviate some of the stress from the like nursing
Oh, no, I
homes?
assume you're going to alleviate it. How long do we have to wait?
Oh, that all depends on how things go in terms of funding. So when I'm working with these dyads through the UCLA model, some of the biggest barriers that I found were folks are not only waiting too long to get diagnosed, they're also waiting too long to get access to treatment and resources. And one of the biggest problems I think that I experienced, I guess the frustration that I experienced is that by the time these dyads were referred to me, the patients and the care partners were so far underwater that it did not matter the number of resources, the number of recommendations, anything that I had in mind that might be able to help them. They were so stressed and really just trying to get like one little grasp of air every now and then that just the simplest thing was too much for them. And so I think that it really does start earlier on, and we need funding for, these people need support, not necessarily, medically speaking, but they need help in the home. They need someone that they can turn to when the person that they're helping care for is starting to experience these behaviors, so that they can learn ways, non-pharmacological ways to provide interventions at home so that they're not contributing more to the stress that leads to eventual placement. We can keep these folks at home with earlier interventions, better support. I don't have a timeline because that's not my job, but I hope that it's coming, and I hope it's coming soon. But I think we're going to have to see how things continue to go in terms of funding and the grant world, and yeah.
Yeah, I'll just, go ahead. Okay. Just, I don't have anything about timeline here, but just a thought is that, I feel like it is so important for us to continue to really focus on supporting those with moderate to late stage dementia, because I don't anticipate that things are going to change really quickly. And I worry that with so much of the conversation and so much excitement around treatments and new medications and all of this, that some of the attention and focus is going to get diverted away from all of these individuals that are still really struggling and are going to be struggling for the foreseeable future. And I think we still need to make sure that we're investing time and resources as a state to support those folks. So.
I would just add that the new treatments that, say, the Alzheimer's prevention treatment that will get approved at the end of next year, probably will slow things down by about 5 years. So either delay the onset of symptoms by 5 years or keep you in the same stage, like keep you in MCI for 5 years. So that really can make a huge impact on the number of people that are progressing to severe cognitive impairment. And so, but you're not going to see that for 15 years. But I think that things will change dramatically with this treatment getting approved, because a lot of people will want to look into that, and there's hope and there's something you can do. And I think this is why I try to use different words and forget everything you knew about dementia and Alzheimer's, because we're in a totally different world now, but that requires these really amazing high touch things. So I do think there will be a sea change, but there's a lot that goes into long-term care, and there's a lot of other factors that,
So, Kristen, have you got your timeline? 15 years.
We'll check in.
Great. I just want to echo what Christina was saying. The longer we can help people stay in their homes, the easier the burden is on the already overtaxed nursing homes. And so that's the way that Adult Days in particular can support people staying in community where they tend to have greater support systems. So we have to support the caregivers and we have to keep our community structures alive. And we do a lot of things so people know who we are. We have volunteers in the community. They come in and they think, oh, this is a pretty nice place. I wonder if my mom would consider coming. And maybe it takes a couple of years. So I think there's just, if we can reduce the burden of the nursing home just by creating those community supports, we'll be really ahead of the game by the time the 10 or 15 years. Thank you.
I have a quick comment. Oh. I'll make it quick.
You just want to joke.
I don't have another joke. So one of the things that we're going to try to do as well is a very aggressive de-prescribing program. So what's happening is with the polypharmacy, and not including just prescription medication, but everything else that you can get in your hand and down your gullet in a day with your prescription medicines means they ain't working. And you're probably on so many of them because they're not working because you're on everything else. So long story short, especially in the nursing homes, when you come in and you were on a med list before you got there, a med list while you were in the hospital, and then a med list that they think you should be on, but they're not taking care of you anymore, we have a huge opportunity.
Yeah.
That's my biochemical pharmacology.
And I see you.
My question's for the two PCPs in the room particularly. I have a lot of caregivers that come to me and they have completely neglected their own health because they're taking care of someone with dementia. So in my mind, when you have a patient that comes to you with dementia, you now have two patients. What are you doing to help the caregivers recognize that they're a caregiver and to make sure that their health needs don't slip through the cracks when
So the first question is, how can I help the patient? The second one is, how can I help the caregiver?
Both are about the caregiver.
Right? No, but that's what happens when you walk in the door, right? It's not only how do we help that person that's the sufferer, how do we help the person that's suffering? And you ask them, how can we help you? What do you need? What can we put you in front of? Who can we get you to help you? So it's a recognition, half the battle is that there's more than one person that has the problem, and that's just the basics of what we do. Otherwise, we're not accomplishing anything.
I always start by just saying, especially if it's a new patient, I'm now part of your care team and we're all working together on this. And so, I'm not going to say this is what you have to do or this is what you don't do or whatever. We're working all together. And I find that care partners, they just feel a lot of relief when they really feel like somebody's in their corner and that they have somebody that now they can call. When they have a question, they don't understand something, something's not going well, if they know that they have somebody reliably that they can turn to, I think that they get a lot of benefit from that. And then also, making sure to refer them to appropriate services, for additional support. Dementia Family Care Centers, great, just all of the additional networks, to kind of get them looped in there is crucial as well.
Yeah, I'm going to come over to Orlando and then I'll go back to Megan. But the Alzheimer's Association has a ECHO program for primary care practices, and I've been able to sit in on some of them, and it's really interesting that the issues that come up are often with the management of the family caregiver. The person with the disease is stable, right? We've got them going on. We do prescribed all the medications. We did all the right, made sure they were safe, all that. Got them into adult day health, all these other wonderful things. And then it's the family caregiver who's kind of the train wreck in the dyad. So thank you for the question.
Can I just add that a lot of them don't know the statistic about care partners die before the patient.
Yeah.
And so just saying that, and if you want to be the best caregiver ever, which you already are, and you want to keep doing that, you need to stay healthy.
Yeah.
And so they do it for the other person still, but at least they take care of themselves.
Great point.
So as a case manager, I find some of my frustration is people, the caregivers not understanding the disease, number one. So that whole piece of argument, mom, who don't have kids, right? To get them to understand that's not beneficial is tough. Lack of in-home caregivers as far as people coming in on the children's care, that we don't have, the lack of a neurologist, all of that. How is a case manager going in? How would you recommend we best support those families? Immediately, I'm thinking because we're in Windsor County, I'm just going to switch them all over to PCPs in Rutland.
I'm trying to retire.
Who wants to answer that? Christina does.
Got lots to say. So I wanted to share the resource that is also involved in this next year's iteration of the BOLD grant, the Dementia Family Caregiver Center through UVM and UVMMC. It is a service that is run by licensed clinical social workers who are designed to, they are trained in memory care, and their main focus is not only caregiver support, but also caregiver education. This is another resource that we offer that is poorly utilized. They offer 2 classes that are designed for caregivers. One is the TEACH program, which is designed for new caregivers, somebody who maybe just received a diagnosis. This is earlier education. And then we also have the Carers program, which both of these are evidence-based tested programs designed for interventions for education for caregivers. The Carers program is much more tailored towards those who are maybe in the moderate to severe stages and experiencing some of the behavioral and mood symptoms. But not just, I mean, even outside of the structured programs, they offer caregiver support services, connection with other caregivers. That is where a lot of the folks that I work with get recommendations. Have you tried this? Oh, my husband does that too. This really worked for us. Have you thought about this? And so really connecting the caregivers with education, support, and resources, whether that's through something that's more structured or if it's through case management social workers. We have also social workers within the memory program who you do have to have a diagnosis of dementia in order for them to see, but the DFCC can start seeing people all over the state. They're remote, they don't have an actual physical building, and so they can pick up the phone and say, hey, tell me a little bit about what's going on and let's find some ways to support you. So there are resources, but I think that this kind of circles back to when I talk about connection, I feel like there's a lot of fragmentation in care, and even individuals like myself who specialize in this, I'm not even fully aware of some of the resources that are going on in the state. And so I think that we need to find ways to better connect people so that we can also connect these caregivers, that the people who are really struggling at home. We need to know everything that's available to us so that we can pass it along to them.
Can I just chime in? I just want to say that we have a similar program in Addison County, the Center for Positive Aging. It doesn't have the structured therapeutic groups that you have, but it has caregiver support over Zoom once a month, and we have another caregiver check-in group as well. We have very affordable counseling program with expertise in aging and dementia care through our team of social workers. $65 an hour private pay or Medicare, government Medicare. So the intent is to really support those caregivers, and I would encourage us to think beyond diet to family systems. How often is it just, there's mom, but the kids think something different? There's often stepchildren involved. There may be former spouses involved. I mean, there's nothing predictable about the family who comes to you and needs help. Yeah.
Yeah, so 2 points. In southeast Vermont, the towns all have CARES groups, right? Not-for-profit, volunteer, supporting the community in any issue they have, mostly medical support and other things. They're retired nurses, they're people that just care. So it takes a village, you've heard it before, really means it when it comes to being able to accomplish a lot of this stuff. I had another thought, but I'm all...
What'd you have for dinner last night?
Is there a
Yeah, so it depends on the town, like Westminster Cares, Putney Cares, I know, Bellows Falls has a senior center. All of these little towns have a touch point, right? And they have programs, they have activities, but they help each other. It's wonderful. And it just, it's everybody, oh, that's what I wanted to say, thank you. So years ago in geriatrics, we had what was called the NICA project, right? And we found out that everybody, including nurses, think that they know more about how taking care of older people in the hospital and when it comes to dementia than they really do. But what did that really tell us? It told us that everybody that came in contact with that patient, no matter where they were in that hospital stay, could have an opportunity to be trained more to be geriatric centric. Well, it says the same thing for dementia. So that everybody who has a touch point, if they're given a little bit of training, how do you keep someone from joking Heimlich? How do you do CPR? This is where we need to go if we're going to do this, because there isn't enough money in the system for everybody to get it. My personal opinion, keep politics out of it.
I see you. Who's next? Oh.
I want to be mindful of time, though.
How are we
It's
doing?
okay, it's okay.
It's okay?
This is important to get the questions, so, please.
So I guess this is a long drawn out. I'm looking at this from an overall, right? So I'm hearing a lot of dedication, a lot of passion within this room. And we're all very privileged to be here and sit here. I'm hearing we need to destigmatize, we need early intervention, we need grief support. And how are we going to get this traction to get it covered under a medical model through insurance? Yeah, we all know what that goes. How are we bringing this conversation to our smaller, more rural communities? Because I'm sitting here and I'm representing a small rural community. I'm representing a AAA, I'm representing a first-hand caregiver. And I want this conversation where I'm at, and in my community. And how can we bring that to our smaller communities and our town meetings, or if that's even, excuse me, I don't know if that's a thing, but or something of that nature, and not just in a room where we're all collectively, we want to do this, we want traction, we want this, we want to move forward. So I don't know if this is, I'm not framing that well, but.
I'm going to take this one and then I'll pass it to you.
That's good.
So I have some colleagues here in the room with me who work for the Vermont chapter of the Alzheimer's Association. Joe Cotto, medical lead. Howard Goodbrow, our chief cook and bottle washer. Jasmine was here. I don't see her anymore, but anyway, they are
here.
Oh, there's Jasmine. She didn't go anywhere. That's good. I was watching. But any of them can partner with you in your community and work with you, offering programs, support groups, helping you to set those things up. Okay, so you guys talk to Megan. And then,
can I just make a comment? Sorry. In tandem with the Alzheimer's Association, is the opportunity for doing a local conversation, right? And there's fantastic educational opportunities through the Alzheimer's Association. And we're also interested in having those local conversations. So we've done several pairings where we do education followed by discussion. What does it look like in your community? What do you need? What's available? What's not? Many of these things are right in 3, 5-year, 10-year time spans. And so as a collaborative, we're very interested in doing that. We don't always have the time to do it, but don't hesitate to reach out to the health department, to the Alzheimer's Association, and we'll see if we can, help with it. Thanks.
we are coming up on time, so I know that Rachel, who is a rock star, because she got called out in the keynote, so I'm going to let her.
I more had a comment/nerd out to somebody's question up front, and would love the panelist thoughts as well, about like when we have a caregiver who is struggling with something we're educating them on and they're having trouble like, processing that information. There's a model that's actually based in smoking cessation called the trans-theoretical model, about like a person's readiness or willingness to change their behavior. And in Skills to Care, we take that model and apply it to caregivers to really understand like where are they in this staging of their willingness her readiness to change behavior, to accept the diagnosis. And then I think that being able to kind of stage caregivers in that way can be critically important to us as providers, because we can tailor our education to meet them where they're at. So if we have a caregiver who's like lower readiness, for example, Dementia 101 is where we're going to meet them, versus a caregiver who's really high readiness. We can like start with strategy development and really brainstorming, you know, what are possible solutions. But that's not an approach that's going to work for every person at every stage. So thoughts from the panel.
She just wrote a thesis, I think.
I think it's what you're saying. It's really important to not just what we're giving caregivers, but really how we're doing it. And so I would just say they're spinning, so it's up to us to be calm and identify is there immediate imminent safety issues. Usually there's not, but there's a lot going on. But that doesn't mean it's going to take 100 steps to fix it. And if we can hold space and calmness and help them find the first step forward, acknowledging that that step might not be the winner. Maybe support groups aren't for you. Maybe you need a different kind of engagement. It's like one small step at a time, but you're like forging this bond with them and you're like, we're doing it together. And if it doesn't work, I'm here. So it can feel like, right, insurmountable when someone's like, and I just had a family member email me like, you know, a scroll and then another scroll email. I was like, oh my goodness. So, but then we had a good outcome during the visit after I took that time to do that. But it's not easy, so I just want to say that.
It's so stressful to be a caregiver, so they can't hear necessarily your wonderful advice, your 20 years of wisdom. I love your model, Rachel. I'd love to talk with you more about it. I'm just realizing that sometimes just what people need is to be heard, and then they can take the next step into what they can do. And that as much as we know, we don't know what's right for them and what they actually can manage. And they've loved this person for however many years, or maybe it's reigniting some trauma for them that their mother's behaving this way. We don't know the depth of that. What can we offer them? We can just offer acceptance and help them get to a place where they can do whatever makes sense for the next step is for them.
Rhonda, would you like to wrap us up?
Oh, wow.
Okay,
so
first,
first,
there.
yeah, no, that's true. Can we thank this?
Podium, please, so they can hear you.
What's? I'm sorry. Is this better?
Could you step
Just
to the
go-
podium?
Okay. Can we thank these panelists for such a wonderful? Amazing array of experience and expertise, and I feel like such a sense of modesty as well, right? Because it's complex, it's personalized, I was just thinking, in listening to this, like if we were to develop, if we had time, wouldn't it be fun to do a word and phrase cloud, like of all of us, and what, you know, words and phrases resonate with you today, whether it's in work that you're already doing, whether it's in what you would like to do. And some of those that appeared in my head, I was hearing, you know, we have some, I'm phrasing, quick changes. We have advancements in science and in care, and I think acknowledgement of not only the complexity, but also that this is truly team-based. Whether it's in the home, in a clinic, at the state level, at a regional level, and kind of stemming from that is that this event today could not be done without a team. And we have a really strong work group, and the slide that you perhaps noticed when you walked in
Those are just some of the partners that help make today possible. But also area agencies on aging, adult day centers, those congregate meal sites. We have 40 of them. We have 40 senior centers in the state of Vermont who try to make it happen, and they don't receive state funding. So there's a lot of pieces of care, and that's what we're aiming to do, is to pull together what we do have as a state from I think the lifespan of both preventing the disease, delaying the disease, and diagnosing and caring for the disease. So we are looking at all those elements. So there's just a few things I wanted to mention in that. So we meet monthly as a work group. Anyone is welcome. You could be a care manager, you could be a caregiver, you could be both of those things. You could be clinical director, PCP. We welcome all to have this conversation on a regular basis. We started meeting, I don't know, 2017, and we've been continuing to meet every month. So first Thursday of the month at 9 a.m., you're all welcome. Just reach out to myself or Tiffany in the back or Ed, and we will put you on the list. Another thing is, as I mentioned before, is that we want your comments, your feedback. You will receive, I think, a survey following this, and you can give us feedback then too. But if you want to do it today, feel free to. We also have, and please stay for 3 sessions this afternoon. These are people who are donating their time to provide their expertise and build, right, the cognitive functional impairment capability of our state. So one of them in the Linden Room is on building dementia-capable emergency responders, right? So important as we try to create the glue in our local communities, and first responders are so important, so critical in so many ways. So that is in the Linden Room, and we'll provide direction too. If you are here and wanting to attend the current landscape of dementia screening and diagnosis, you're going to be in the Red Oak Room. One of the things I want to mention about this one is annual wellness visits. So at the health department with partners, we are promoting the annual wellness visit. Nurse-led annual wellness visits, it's evidence-based, it's reimbursable. It helps to provide a routine care and I think also in a way of cognitive screening as part of our aging. And I think we can destigmatize it through annual wellness visits. So we've been promoting it. We look forward to your joining that, which will also be joined by Christina, right? You're in that. Christina is fabulous. She is our first dementia specialist in Vermont. We are hoping to get more dementia specialists. Yes, using the UCLA dementia care model, but tailoring it to Vermont at the same time. So if you want to learn more about that, go to the Red Oak Room. And then our third one is around dementia-related behaviors. We are very fortunate to have Rachel Wiley, Dementia Collaborative. She's part of our work group. Dementia-related behaviors, so there's prevention strategies to those. And so Cherry Room will be your room for that. This room, Rachel. We're going to take a photo of our panel, so do not move, okay? And also, I think that Dr. Cabral, I cannot thank you enough for coming to Vermont. When I reached out to you, I thought there's no way. And wow, you said yes. You're here. I think that it's such a powerful message, and I was the one, I admit. I was like, what? High touch, high tech? You know, we're a rural state. We have so many, challenges. And what you're doing from a researcher and from a provider, I think it's amazing and it's inspiring. And I think we will be able to take elements of what you do and find ways to do it in Vermont that helps give people, even who are maybe genetically disposed to have hope and also to have specific actions that they can take. And that's what we're seeking to do in our work. So thank you so much, and thank you everyone for being here. There is lunch provided. Help yourself to what's out there. And there's also our cafe if you want more than that. And Ed, did I miss anything? And we will start to convene you for the afternoon sessions at 10 till 1. Okay, so you have a break until then.